little bit tonight, but so we're already in week 7. We're almost halfway there. When we get into primary care and dealing with endocrine, is this something that you guys are going to be dealing with? Absolutely is the correct answer. And maybe it's not managing throughout the entire disease process, but we're going to be doing a lot of the diagnosing. We're going to be doing a lot of the referring. And then of course, even when those patients are managed by specialists, they're still coming back to us when they get a cold or a flu. So we have to know all of those different medications anyway, right? So we're going to start off talking with drugs that we're going to use to manage diabetes. So when we are managing diabetes, there's 3 categories that we're going to focus on. It's going to be insulin, non-insulin injectables, and then we also have anti-diabetic medications. So just a quick refresher as far as what diabetes is. We know it's chronic. It is going to be progressive. So these patients have abnormalities in glucose, protein, and how they metabolize fat. So all of those 3 things is going to result in them going into a hyperglycemic state. So diabetes, we've got 4 different clinical classes that we divide them up into. So type 1, this one is when we have what type of cell destruction? Complete beta cell destruction, right? So do they make any insulin? This is going to be our absolute insulin deficiency. Type 2, this is going to be a progressive form in which they don't secrete enough insulin or they become insulin resistant. Then we have other causes that can cause diabetes. So we can have genetic defects where they have something wrong with those beta cells. We can have genetic defects in how that insulin actually works in the body. We can have diseases of the pancreas itself. So diseases like cystic fibrosis that affect the pancreas can lead to a diabetic state. And then the last one we have is gestational diabetes, which you'll see is GDM. So this is going to be diagnosed during pregnancy, and usually it goes away after they deliver the baby. So first one we're going to talk about is type 1. So a couple of different things that are going to happen for a patient that is type 1. This is only 5 to 10% of the diabetic patients that we are going to see. So this is an autoimmune process where the patient's own body is going to destroy those beta cells of the islet of Langerhans within the pancreas. So we said this one is going to be absolute insulin deficiency. Type 1, we used to call it what? When did it start? Yeah, so this was juvenile diabetes, or you'll hear it insulin dependent or IDDM. So risk factors for type 1 diabetes. There is a genetic component, so we know that family history of it. And there's also the environmental and autoimmune components. 70% of your type 1s are going to become type 1 diagnosed diabetics by the time they hit 30, which is why we always refer to it as juvenile diabetes. It can happen at any age, just most commonly it's going to be early on. So do we have any kind of cure for diabetes type 1? Not technically, but there's a lot of things that we're working on. We've talked about some medications that we have seen that stop the progression of the disease breakdown of those beta cells. So we've already talked about what is that one drug? Verapamil, that in mice we have seen when we give verapamil, it stops those beta cells from being destroyed. But then the concern is, do we just want to give everybody verapamil just in case? Probably not the best idea, right? Type 2, this is going to be the one that you guys see way more commonly. 90 to 95% of the diabetics that we're treating are going to fall into the type 2 category. So this is going to vary in how often we see it in the United States based on the patient's ethnicity, based on their race, based on their age. So we see a higher frequency in what populations? Hispanic, Native Americans is going to be huge, Asian Americans, Pacific Islanders, and African Americans. They're all going to be at a higher risk. Then we have the lifestyle risk factors. So what does a patient look like that we're like, oh, you're at risk for type 2? Metabolic syndrome is a huge risk factor. What else? Obesity is a huge one. How do we become obese? Sedentary lifestyle, already having hypertension, already having dyslipidemia, gestational history, and then also their age are going to be risk factors. So we know genetics is becoming a huge focus as to what we're looking into to see why do patients develop type 2 diabetes. So we've even found the one chromosome that we can link to patients developing type 2. So if you both have type 2, mom and dad, your offspring is going to have a 15% chance of also becoming type 2 diabetic. So big thing with diabetes, yes, we have to worry about hyperglycemia and we have to worry about them going into DKA, but the biggest thing is those long-term risk factors, right? So all of the scary things, like when we scare our patients with hypertension, we can also scare them with a lot of similar things for the diabetes complications, right? So when we talked about hypertension, what was always our main goal of treatment? We wanted to prevent what? What was that called? When those other organs weren't affected? End target organ damage. Remember, with hypertension, we don't want it to affect the kidneys. We don't want it to affect the eyeballs. Guess what? Very similar with diabetes. So we want to stop all of that little microvascular complications that diabetes causes. What kind of organs are affected by diabetes? The eyes. The kidneys are huge. The heart. Yeah, the entire nervous system. Think about the neuropathy that develops with our diabetic patients. So retinopathy from that eye complication, we can have our patients lose their vision. Neuropathy, nephropathy that leads to renal failure. What about all those foot ulcers? That's also those microvascular complications that end up with amputations. We can have neuropathy that affects the GI system, the GU system, the cardiovascular system, even sexual dysfunction. So if I had a patient that came in and I was concerned that maybe they were showing signs and symptoms of diabetes type 2, I'm going to be doing a workup for them. How many body systems do you think I'm putting on my review of systems? 12 to 14. Yeah. How many body systems do we have? 12 to 14. It can affect literally everything. So if I'm concerned about a diabetic patient or a patient becoming diabetic, I'm doing a thorough review of systems. Does that mean I'm only asking 2 questions in every body system? That means I'm asking a lot of questions in every body system, right? I'm saying probably like 5, 6 pertinent negatives that I would want documented. Just because something's negative, do I leave it out? Do I document it? If I document it, I did it, right? If I leave it out, I don't know if I did it. So that's going to be really hard for me to have a baseline. So if I do have that obese patient that's sedentary that I'm worried about, but maybe their labs come back normal, would it be important for me to have that baseline so that I can look at it when they come back next year and now they are diabetic? It'd be really important for me to know all of those negatives, right? Because then I actually know what changes. Where if I don't have it documented, I don't know if it changed or did I just not ask them it last time, right? So this is a really, really detailed, big, extensive SOAP note. So macrovascular, so when it affects all of the bigger blood vessels, atherosclerosis is going to be huge in our diabetics, peripheral vascular disease, CVA, these patients develop strokes. So all of that cardiovascular is going to put them at risk for hypertension. We're going to see abnormalities of lipid metabolism. So we're going to start to see hyperlipidemia. We're going to see abnormalities in even their platelet function. We even see periodontal disease. So that might be a key indicator that I need to work my patient up for diabetes. So who do I care about screening for diabetes? You're just going to screen everybody? Your clinic is going to be pricey. So here's our screening for type 2 diabetes. If my patient's 45 and they have a BMI greater than or equal to 25, we're going to test them. If they come back normal, I can decrease testing to every 3 years. If they're under 45, but they have a BMI greater than or equal to 25, but they also have additional risk factors, we're going to do more frequent testing. What would be some of those additional risk factors? How about anything we just talked about? All of those little complications, all of those ethnic disparities that we said are going to be at higher risk. Age is going to be a factor. So 45 is kind of a key number for us here, right? So those additional risk factors, we said physical inactive, so sedentary lifestyle. First degree relative, we know you're going to be at a higher risk. Member of that high risk ethnic group that we just named. Additional risk factors that we also have to take into consideration, A baby weighing more than 9 pounds. Has anybody had a baby that weighed more than 9 pounds? God bless you.
Focus was 9 pounds on the dot.
On the dot. So we're going to still give you an additional risk factor. Sorry about that. So greater than 9 pounds gestational birth weight, or if you had previous gestational diabetes, that's going to be a risk factor. If you're hypertensive, if you have high cholesterol, if you have triglycerides that are high, if you have a history of PCOS, that's going to be another risk factor. If I've seen an impaired glucose intolerance test or an impaired fasting glucose, or any other clinical condition that is associated with insulin resistance. So remember that acanthus nigricans, what was that? Remember that, the discoloration on the back of the neck. That's a risk factor, just that in itself. So if I'm screening them, what do I actually have to see in order to diagnose them with diabetes? So here is our diagnostic criteria. So if they've got acute symptoms of diabetes plus a casual plasma glucose concentration greater than 200, guess what? You just got yourself a diagnosis of diabetes. Fasting plasma glucose greater than 126. 2-hour postprandial in an oral glucose tolerance test where you come back greater than 200. An A1C greater than 6.5. All of those, as soon as I do that, I am going to diagnose you with diabetes. If I come back, so let's say that A1C, it says greater than or equal to 6.5. So my patient comes back with a 6.5. On their assessment, do I automatically put diabetes?
Yes.
Does this say that is a diagnostic criteria? Yeah. Does that diagnosis always have to stay on there? So if I'm anywhere on that borderline, is my patient able to bring down their A1C? Hopefully, right? So that 6.5, we might say, okay, we really need to focus on your diet. We really need to focus on your exercise. When are you bringing them back for a repeat A1C?
3 months.
3 months is the bare minimum, right? We don't want to do it sooner than that because we don't see a change in our A1C. So if they come back and now their A1C is 5.7. Good job. So now I can take diabetes off your assessment list. So most EHRs, what I would do is I would click on that diabetes diagnosis, and there's going to be a button that I can say resolved. So it's going to stay in the background of their chart. So if I ever go to add another diagnosis, it might pull it back up. So I can see, oh, hey, they were this once, it resolved, but here we are again. So it's going to tell me that maybe we didn't really accomplish all of our education goals, right? So for our pre-diabetic patients, if we've got an fasting plasma glucose 100 to 125, we're going to diagnose them with pre-diabetes. Plasma glucose 140 to 199 at 2 hours postprandial, pre-diabetes, and then that A1C that falls in that 5.7 to 6.4, we will consider pre-diabetes. Does pre-diabetes have its own ICD-10 code? Everything does. So of course, pre-diabetes is going to have one, and it's probably going to have one even as specific as A1C 5.7 to 6.4. So we know why they fell into that criteria. All right, so we are going to first talk about insulin. Who has this medication? Don't tell me. Yeah, is this you? Okay. I'm gonna have you tell me about insulin, Alexa.
Can you hear me okay like this? Can I just talk loud?
Can you guys hear her on Zoom?
Because I don't talk very loud.
Not really, barely.
She said, talk loud.
I mean, I can, but it's not really. Okay, can you hear me now? All right, so regular insulin, also known as Novolin R and Humulin R. Short-acting insulin, its goal is reduction of blood glucose. Regular insulin has an identical structure to that of native human insulin. Within the liver, the insulin stimulates hepatic glycogen synthesis. Insulin promotes hepatic synthesis of fatty acids, which are released into the circulation as lipoproteins. The onset is 10 to 21 minutes. Peak effect is 5 hours. Side effects can be hypoglycemia, weight gain, peripheral edema, injection site reaction, lipotropy at injection site, hypokalemia. Contraindications would be any hypersensitivity to regular insulin or its formulation, or during episodes of hypoglycemia. The precautions for glycemic control, the hypoglycemia may result from changes in meal pattern, such as macronutrient content, timing of meals, changes in levels of physical activity, increased work or exercise. Hypokalemia, the insulin causes a shift of potassium from the extracellular space to the intracellular space, possibly producing hypokalemia. If left untreated, hypokalemia may result in respiratory paralysis, ventricular arrhythmia, and even death. Okay, really hot up there. I get so nervous. Okay, bariatric surgery. If I pass out, just
Now you know how I feel.
It's fine. Blood pressure, everything. Bariatric surgery, type 2 diabetes, hypoglycemia, closely monitor the insulin dose requirement throughout active weight loss for the goal of eliminating anti-diabetic therapy or transitioning to agents without hypoglycemic potential. Weight gain insulin therapy is preferred if anti-diabetic therapy is required during the perioperative period. Evaluate risk versus benefit. Cardiac disease, concurrent use with peroxisome proliferator activated receptors, or PPAR, gamma agonists, including thiazolidinones, TZDs, may cause dose-related fluid retention and lead to or exacerbate the heart failure, particularly when used in combination with insulin. Continuing on monitoring, we're going to monitor the blood glucose, electrolytes, and weight. Patient education, be sure you have the right insulin product. They come in several different kinds of vials, so make sure you've got the right one. Watch your low blood sugars, avoid driving and doing other tasks until you know how this drug affects you. And then, do you need me to go into administration?
No, because we're gonna go into that.
Okay.
Thank you so much.
Thank you.
Do you guys know why I'm having you teach as far as drugs, other than it's awesome for me that you guys take some of the load off? You already have that. You're in the NP school. So as a nurse practitioner, are you guys going to be educators?
Yeah.
100%. You're going to be educating your patients. You're going to be educating their families. You're going to be educating your staff too. So getting comfortable kind of taking the lead role, because that's a big shift, right? As nurses, of course, we do education, but we're kind of doing what somebody else has told us to do because they diagnosed it, right? Guess what? We don't have anybody diagnosing for us. This is on us. So I just want you guys to try to start getting comfortable in that more of a leadership role. And maybe we need to just take some propranolol before you come up here to help bring everything down. I don't know. All right, so big thing with insulin. This is going to just be shifting the way that our own body is metabolizing that glucose, right? It's not going to make our body start producing insulin if we don't make insulin. This is going to be synthetic insulin that we can put in to get our body to metabolize glucose and break it down the way that a normal body would. So this is probably your most important slide that we're going to talk about. There's going to be several questions that you're going to see in your midterm, probably some in your final, and especially on your board exam of how and what we do as far as diabetes. So I'm sorry, that should have been like the whole slide instead of just a part slide. So knowing that the rapid acting, I would want to know the names of those. So Humalog, Novolog, Apidra. The generic names of those are going to be Lispro, Aspart, and Glulisine, or I might have done that opposite, sorry. Know that those are all of our rapid acting. Rapid acting, how quick does that work? That can be 5 to 10 minutes. We're talking rapid acting. There's going to be those 3. Glulisine is your prototype for that one. So that's the one that I really want you guys to focus on, do your reading on. Did anybody have just Glulisine? Or was that you? Was that you? What did you have? Or did you just have basic insulin?
Just Novolog. It just said Novolog on the list.
You had Novolog? Okay.
Yeah.
So everything that she just told you, we're going to say the same for Glulisine because it's falling into that same rapid acting family. Okay. So 5 to 30 minutes, but how long does it last? Anywhere from half an hour to only 3 hours. So it's going to work really quick and it's going to phase out of the body really quickly, right? Then we have our short acting. So that's going to be your regular insulin or your Humulin. So this one, what's our onset? This is a quick acting, but not that rapid acting, right? So we've got 30 minutes to an hour. It's going to peak at that 2 to 4 hours, and it can last anywhere from 3 to 7. Then we have our intermediate acting. So isophane, did anybody have NPH for their drug? Okay. Can somebody tell me what NPH stands for? What? Something Hagedorn. What's the NP part? What is it? Are we guessing?
Yeah.
I don't know. I'm asking you guys. What's the NP stand for?
I think it's neutral protamine.
That sounds much better than natriuretic peptide.
Neutral protamine Hagedorn.
Neutral protamine Hagedorn. Hagedorn. If I saw a test question that came back neutral protamine Hagedorn, I will tell you, the first time teaching pharmacology, I was like, what in the hell is that? I've never heard of that, because I've never seen NPH written out. I've only ever seen NPH. So I'm telling you, if you had a test question that came back neutral protamine Hagedorn, your brain should do better than mine and be like, that's NPH. Okay. So NPH is going to be our intermediate acting. So onset 1 to 2 hours. This one's going to last from 4 to 10 hours and going to have a duration of 10 to 16. Then we're going to get into our long acting. So our Lantus or Glargine, and then Levemir or Detamir. So onset, these are going to take 1 hour to 2 hours to even kick in. We don't really have a peak because they're just going to have that slow, steady output for about 20 to 24 hours. Then we have fixed combinations. So this is when we're dosing that NPH, which is that intermediate acting, along with a regular. So we're going to have a duration depending on what that ratio is of NPH to regular. So peak, we have to have that dual of what is the NPH peak at, what is that regular peak at. And these are going to last 16 hours. So this is a chart that I want you to become very familiar with. This is the one that I would like highlight. I would probably memorize. I would know what the generic names are and the brand names of these are. All right, so I just did some clinical pearls for you. Big thing that you need to know, dosing. 50% of our insulin is going to be a bolus dosing. 50% is a basal dose. What does basal mean? Basal is around the clock. Okay, so half of it I want controlling from here on out. Half of it I want right now. Okay, 50 bolus, 50 basal. We're going to have to change these depending on our patient's activity level, what their blood glucose readings come back as, what type of diabetes they have, what's their average insulin dosing. So if you diagnose that patient as diabetic, do you feel comfortable managing their care?
No.
Ever? As a new grad, do you feel comfortable managing your diabetic's care? No? So what are you going to do?
Consult.
I'm going to consult with an endocrinologist. I'm going to refer them over there. I probably want the endocrinologist managing their diabetes. I'm going to manage everything else, right? So family practice, remember, I'm just kind of the quarterback. I'm calling all the plays and I'm directing them where to go, but that doesn't mean I have to manage it all. Unless we're in like a rural setting, then we might not have an endocrinologist that's within our patient's range of where they can go, and we might be managing it, but I can still do a consult with endocrinology. How do I decide when I'm going to refer anybody? Your comfort. That's the easiest answer. That's going to change throughout your career, right? There's going to be a point in your career where like, hey, you're type 2 diabetic, you're kind of borderline. I feel really comfortable managing this, and that's totally fine. As long as you have the confidence and the knowledge to back it up, you guys can manage these conditions for sure. Otherwise, you can read the article that I just published in Arizona Journal of Nursing that's entitled When to Refer. Mine's specific to pain management, but it really was just saying, if you're not comfortable, refer. If you have questions, do a consultation. That's why all those specialties exist. That's why I know a whole lot about one subject, because I'm a specialty where you guys get to know a whole lot about a whole lot in family practice, right?
Like with endocrinologists, there's like a shortage of them. Most patients will say they are waiting months, like 4 to 6 months to get in. Would you not do anything?
Did you just ask if you would want to kill the patients by not treating them? So this is where you really have to set yourself up for success at your first job. So your first job, if you're not comfortable managing things, you have to have somebody next to you that you can do a consultation right now. So that means finding a job with either a nurse practitioner or a physician that loves teaching, that has time to spend with you, so that you can go to them and say, oh, I just diagnosed a newly diabetic patient and I'm scared, please help. And I want that new grad to come to me with ideas, and I want to be a sounding board. I don't want to tell you what to do, but I want to collaborate with you, and I want you to tell me your ideas, and we come up with a treatment plan together to go back to the patient. And we've talked about this before, right? So if you come to me, even though I'm a colleague, I'm in the same practice, are you documenting that you're coming to me? Absolutely. And I would expect, if you come to me to consult, that my name be part of that chart, that I now am partially liable for what's going on with the patient, because you did come to me for my knowledge. So make sure you're setting yourself up for success is my best answer, because I'm never going to diagnose somebody and then say, oh, sorry about your blood sugars being out of control for the next 3 or 4 months or 6 months until you can get into endocrinology. What if my patient doesn't have insurance? Do you think they can afford to go to a specialist? So there's going to be a lot of times that maybe I just have to manage these things. So make sure that we have somebody that we can collaborate with. And I don't think they're going to kill people, don't worry. You'll think so when you first graduate, but you guys you're going to know so much more than you even realize that you know. So most patients with diabetes are going to see an endocrinologist, and that's one of the big takeaways that I want you guys to get with this. Treatment with diabetes is going to be challenging because it's always changing, right? Our patients become more active, less active. They change their diets, they get stressed out, they get sick. Everything's always fluctuating. So having a specialist on board, absolutely, with our diabetics. Certified diabetes educator is crucial. I just had a patient that she was newly diagnosed. She was seeing her primary care for her diabetes. And I said, well, did you see the nutritionist? And she said, no, why? And I was like, so are you counting your carbs? And she said, what? Oh, so your primary care is not doing a good job, or she's not retaining. I don't know which one, right? Because her primary care could have told her all of these things, and she just heard, I'm diabetic, and then left the consultation. So getting a nutritionist on board is huge, right? Because that's where we get all of our glucose intake, is exogenous glucose. So endocrinology and a diabetes expert as far as nutrition. When we do make changes in any of their insulin, we're wanting to do it slow, low and slow, just like we do all of our other medications, right? So we want to do this very gradually. So if I'm making adjustments in your insulin and I want to do it gradually, what am I going to tell you to follow up?
3 months.
3 days. I might, if I'm really worried about you, I could definitely do 3 days, but usually about a week. So if I'm just increasing, we're going to go up 5 units on your insulin. Let's check back next week and check your blood sugars together. Go over your dietary log, see where we can still make some improvements. Ongoing follow-up is going to be crucial. So I would never let my patient leave the office without having their next appointment scheduled, right? We don't want them to go out into the world and be like, oh, I don't know when I'm supposed to follow up. I'll follow up when I'm sick or when things go poorly. I want them to know, nope, we have an appointment in 1 week, 1 month, 3 months, whatever the case might be. And they're scheduling that before they ever even walk out the door. When I have that newly diagnosed diabetic, do you think we're gonna be aggressive, we're gonna get control of that blood sugar, and it's gonna be really easy. We're gonna see huge fluctuations in their blood glucose levels as they learn, as they become more active, as they get better control. That's to be expected. That doesn't mean that they come in with high blood sugar and we're disappointed or we have failed. It just means we need to do more education. We need to collaborate with our patients better. So we expect that big variability, especially at the beginning. So if we have these huge fluctuations in blood glucose, what are some things that I can educate my patient on to try to get more stability in there? What would you tell them to do as far as maybe meals? Snacking all throughout the day, 3 big meals. What are you going to tell them? Sugar-free anything, right? But really we need consistency. So if they are doing 3 big meals, okay, but now we need to know how to dose before each one of those 3 big meals. Or if they're going to eat 8 small meals, we need to know how to dose in between all of those. So our big thing is we just want consistency. We don't want them changing their dietary habits from one extreme to the other. So a treatment plan, do you think I can have a write-up and I'll just go grab it out of a folder and be like, you're a diabetic, here's your treatment plan? What do you think my treatment plan looks like? Completely individualized, right? Because it's going to be different from my weirdo that exercises 7 days a week versus my person that hasn't worked out in the past 7 years, right? My treatment plans are going to look very different. So we have to make sure that these are going to be very individualized based on what our patients' daily activities are. Okay, so now we have our oral diabetic agents. So this, again, we're just trying to get their A1C as close to normal as we can. Ideally, we want it less than what? What's our goal? 7 is going to be our goal. We want less than 7. So oral diabetics, is this my type 1? This is going to be my type 2. Yep. So when you come in and I diagnose you with type 2, am I going right to oral diabetic agents? What am I? Oh, it can depend on their blood sugar. Sure, if they're like crazy high, we might know that insulin's going to have to go in there, right? What is my first thing that I'm going to recommend? Lifestyle interventions. Yeah. So we want diet, we want exercise, and then we're doing a lot of education. First line therapy, what do you think our most common drug is? Metformin. Yep. So we're giving them those glycemic controls. So we want that A1C less than 7. If we don't achieve it within those first 3 months, when we recheck the A1C, and we're doing that oral metformin, we're at maximum dose, what do you think I do now? Now I need to add another drug. Yep, just like I would with hypertension, right? I'm already maxed out, so now I need to go to the next drug. So we can do those GLP-1 agonists, we have DPP-4 inhibitors, or we have insulin. If I have added metformin, I'm maxed out, and their sugars are still coming in, we're in like the 400s, 500s. Are you going to pick one of those other oral medications as your second line treatment? What are you doing? Insulin. Yeah, so those ones that I really can't control, I'm just going to up it. I'm going to go right to insulin to get them under control a lot quicker. So your oral diabetic agents, these are for patients that don't make enough endogenous insulin. So they're going to target the tissue insensitivity. So anytime we've got impaired response of those beta cells, or we've got excessive production of glucose by the liver, we can start implementing metformin. So our goals for these medications, we want to get near normalization of blood glucose. So our A1C goal of less than 7. Remember, these are going to be individualized based on age. If they're pregnant or if they're older, we're going to give them a little bit of leeway. We want to prevent them from any acute complications and chronic complications. So we want to prevent that end organ damage. And then making sure we're doing appropriate self-management. So some of our treatment goals that we're going to focus on. So we want glycemic control. That's our A1C that is going to be less than 7. We want, before they eat, their glucose should be no higher than 130. So 70 to 130 is going to be our range there. After they eat, we're going to have them recheck it 2 hours later, and we want it to be less than 180. Our blood sugar or our blood pressure goals, we want less than 130 over 80. If they're diabetic and have hypertension, we're going to allow them to go up to 140 over 80. Lipids, we want LDLs less than 100, triglycerides less than 150, and HDL greater than 50. Anytime we check a random urine albumin, we want creatinine less than 30 mics per milligram of creatinine. So our rational drug selection, this is going to be based on what type of diabetes our patient has, right? So we know our type 1s aren't going to be getting oral diabetics. What is that glycemic target for the patient? How severe is their hyperglycemia? And then of course we have the patient variables based on their age, if they're pregnant or if they're elderly. So you guys are going to be following ADA guidelines, and then we've got different algorithms based on type 1 and type 2. So when we first do that initial assessment of our diabetics, we're doing a really thorough history. So when we're talking about our symptoms and we're doing our ROS, we're asking about every body system because it can affect everything in the body, right? We want to know about their current drug history, and that always includes our over-the-counter. So I always ask my patients, anything that you put in your mouth that is a pill form, I need to know about it, not just something that's prescription. Family history. So we know you're at a higher risk, especially if both of your parents are type 2. I want to ask about all of your risk factors. So smoking, where am I asking about that? Social history. What else in my social history is going to gear me towards putting a red flag about diabetes type 2? Diet, exercise, stress have an impact on it. Yeah, so hobbies and leisure activities. So a lot of what you do in your day-to-day activity is going to let me know how high your risk is for developing type 2. Our physical exam. So we asked in our review of system about 12 to 4 body systems. How many body systems do you think I'm doing an exam on? All of them, pretty much, right? So everything from your eyeballs down to your toes, diabetes can affect. What labs are you guys ordering? Hopefully an A1C.
Cholesterol, kidney function.
Yeah, I need to know your kidney function. I need to know your cholesterol. All right, so those glycemic controls, anytime we can get an A1C less than 7, we're going to have way better long-term outcomes. We see fewer of those microvascular and macrovascular complications. If we have really good control and our patient's doing well, can we set that goal even higher? What's a normal person's A1C with no diabetes? Less than 5.7. So if I have a well-controlled diabetic and they've been doing good, can I give them the goal of let's get you down to 6.5? Absolutely. That's even better control of your A1C, right? So a lot of times, what would be a concern about getting their A1C too low? Hypoglycemia. We might be overcorrecting and kind of overshooting our landing there, right? So important factor is going to be, do they have enough instruction? Have I given them enough education? And have I been able to have them do a teach back? How do I ask them to do a teach back? What are you guys asking to know? Do you have good knowledge of your own medical condition? What kind of things would you want to hear from your patient?
When should you be checking your blood sugar?
When should you check your sugar? Great one. What diabetes is? What symptoms are showing both hyper and hypoglycemia, right? So we want to know that they have a really good understanding as to what's happening in their own body. So we talked about lifestyle modifications for our type 2. Is it specific for type 2? It's good for everybody, right? So all patients, we want to get to that diabetes educator for that self-management, because we do want this to be a very individualized plan. We don't want our patients to think that, you know, here's your list of foods and these are the only things that you can eat every single day. No, we can incorporate some of the foods that you like, as long as we're balancing that out with insulin or exercise, depending on what kind of diabetic you are, right? So we want to make sure that this is all individualized. So we want to try to give them targets, and if they are meeting those goals, then we can even up those goals a little bit, modifying their nutritional intake as appropriate. And then overall, we're trying to improve their food choices and their physical activity. For kids, our big thing, we need to make sure that they're adequately growing, and for pregnant women, that they're maintaining adequate energy. So we are going to help out with medication management and the education, but this is really going to be a self-managed diagnosis, right? Our patients have to give themselves insulin. So we have to take into account all of our patients' capacities. What do I mean by that? She says. So making sure that they're understanding, right? If I just start throwing out words about your insulin secretion and your A1C percentage, does that mean anything to anybody? So if I did take into account the average reading level is what? Fifth grade. How am I going to educate my patient to actually control their diabetes?
We're gonna simplify it.
We have to simplify it, right? We have to tell them your food has sugar in it. Does all food have sugar in it? So think of, and I just think of like a young kid. And if you told a kid, I need you to go pick a healthy option, what would they go grab out of the fridge? Fruit. Does fruit have sugar in it? A ton, right? So we have to get our patients to understand the different types of sugars and where they live in all foods so that we know how to teach them to compensate for those things, right? And then we can also do the scare tactic, just like hypertension. So what risk factors are we warning them about? You're going to end up with no legs, blind, on dialysis, right? You're hobbling there, but you can't find the door because you're blind, and you're going to be sitting there Monday, Wednesday, Friday because your kidneys are shot. And I don't do the scare tactic. I mean, I guess I do to scare them, right? But it's really, I think so many people think, oh, I have this disease, it's going to kill me someday, that's fine.
But these are the consequences.
But these are the consequences of if you don't die, you're going to have to deal with this. And guess what? If you don't deal with it, your loved ones are going to have to. I just had this conversation with a patient. Her blood pressure on Tuesday was 199 over 101. And I looked in her chart from last month, and in all caps, I had patient needs to follow up with primary care regarding blood pressure. And I go in and her blood pressure is 199 over 101. You know what I told her about her pain pills? I said, there is no point in me giving you these if you're not going to take care of yourself. So you get your blood pressure under control, or I need to wean you off medications because you're not helping yourself. Why should I help you? Sounds pretty harsh and mean, right?
What's she saying?
She said, I know. And but I told her, I said, from what your blood pressure is right now, you're at a hypertensive emergency. Your risk for your head popping off right now is so high that you are gonna have a stroke. You are gonna end up killing your kidneys. And that's what I always tell them is it's not about you. It's about your daughter that now has to come to the hospital after you have a stroke and you don't know who she is. And that gets to them way more than, oh, I'm gonna die someday. So sometimes we just have to find out the things that they care about and use those, not really, I guess, against them. I use it to help them. And when we were walking out of the room, I said, did I scare you? And she said, you scared the shit out of me. And I said, good, because I fully expect that when she comes in next time, if she comes back, that her blood pressure is going to be under control, hopefully, right? Or at least not 199 over 101 where it's going to pop off. All right, so drug therapy, our type 1s, pattern of how we are going to have our patients administer insulin. This is based on what their blood glucose levels are, what does their diet look like, what does their lifestyle entail. So regardless of the type of insulin that we're going to use, we want to mimic endogenous insulin. We want the body to think that it is producing insulin the way that it does when we naturally produce it, because we want to be able to correct that hyperglycemia. So intense insulin therapy, we're going to do split mixed insulin therapy, or we can do a continuous subcutaneous insulin injection. So that's where they're getting the insulin pumps. So daily insulin requirements are going to be 0.3 to 0.5 units per kilo for their body weight. And then we titrate it based on their glycemic targets. When is my patient going to need more insulin? When they get sick, when they get stressed is even going to increase their insulin. What about if What if they're exercising and they're using up more glucose? So physical activity, we're gonna have to adjust it. Do I care more in this instant when I'm giving them insulin? Do I care more about hyper or hypoglycemia? Care about hypoglycemia, yeah. So we need to take that into consideration first. So when I'm adjusting insulin, I might be adjusting it just on 1 to 2 units. I'm gonna do increments that small. And you guys have all given insulin, right? I think that was my first, what did they call them in the hospital? Near miss. The very first time I ever pulled up insulin, like 20 years ago, and you don't realize like it's microscopic, right? And so I think it was like 6 units, and I was like, that can't be right. And pulled up the 60. Well, luckily I was a student, so we did a med check and it was a near miss, but I didn't realize that much insulin does that big of a deal, right? Is that important to teach our patients? Really important, because what else is really important? Eyesight. Those increments are tiny, so I can overdose, I can underdose. Really simple to make a mistake on those tiny little injections, isn't it? Did they kill somebody?
No, it was a new grad that the preceptor caught it before injections.
Was it me?
I had a family member unfortunately do that.
And kill somebody?
I was supposed to get 10 and do 100.
Oh.
So yeah, it's hypoglycemia, which I wrote about. The
Yep.
sister never told me, and I was saying this is fault, but she was like, I will carry that burden.
I've also, I shouldn't say this on video too. but I've also told my husband, like, if anything ever bad happened to me,
Oh, absolutely.
between the toes.
Absolutely. And just
Nobody will ever know. It's your body makes insulin. You can't find it on an autopsy. I'm not giving murder ideas. I'm just saying for euthanasia purposes. All right, so some basic knowledge before we dose insulin. For every 15 grams of carbohydrates, this is going to raise your blood glucose level by about 50 milligrams. Who has a drink that has a label on it? Right? Does anybody have a label? Can you, are you guys all diabetics in here? You're just healthy. Nobody has a label that we can even look at? So how many things have 15 grams of carbohydrates?
Almost everything.
Most things, or way more. I actually love Mexico. Is their labels are crazy. Like all of their labels say excessive calories, excessive sodium. Yep. They're way more proactive. If you buy a pack of cigarettes, it's got an intubated patient on there, or it has a prenatal preemie on there. They're pretty terrible. Do you have carbohydrates on there? So what do you have? What is it though?
Fancy trail mix.
So she's got a fancy trail mix that has 27 carbohydrates. That's gonna raise your blood sugar almost 100 points just from that one little package. Would it be important to maybe even have some of those packages in your office to show your patient, like, just eating this? So you're just hungry, you just grab something to snack. Most of us don't think about it, but now your blood sugar that was 200, which was already high, just that one little package, now your blood sugar is 300. Is that important?
Mm-hmm.
Think about eating like a Reese's peanut butter cup. Doesn't anybody have any good candy or anything in here that you can? What do you got, Teja?
I just hate mine.
So
I think just even your bright orange, I think has got way too many. What's your Oreo carbohydrate? So she's got Oreo carbohydrate is 36 per one serving.
Don't ruin Oreos.
Because you also have to take into account serving sizes, because most of the time if it's 2 Reese's peanut butter cups, they're going to give you 1 serving, but there's 2 Reese's peanut butter cups in there. Who only eats 1 Pop-Tart? What are you going to do with that other Pop-Tart? It's going to go hard and stale. Okay, so we've eaten one Oreo and now our blood sugar is up 150 points. But look at 1 unit of insulin can bring down my sugar 20 to 60 points. So we can see how those tiny little incremental doses can make big changes in getting our patients back under control. So our big thing here, we want to determine what is our carbohydrate to insulin ratio. And then remember, we're splitting that basal rate, that around the clock, with our bolus rate. We're going to do 50% and 50%. Initial dose of insulin, so it's that 0.3 to 0.5 units per kilo per day in divided doses. I feel like I've said that a couple of times. That's weird. All right, so our type 2 diabetes. This one is also going to have an algorithm for us to follow as far as trying to get our patients under control. Always starting with what? Lifestyle modifications. And then first drug is going to be metformin. So a lot of times when we just do those lifestyle modifications, it's going to be hard for our patients to achieve those goals that we're setting out. So a lot of times we are adding in medications, but we always want to start with those lifestyle modifications, and we always want to encourage them to continue them. So I've done monotherapy for 3 months. There's no reduction in A1C. Now what am I doing? I'm going to do a stepwise approach, and we've got ADA guidelines that we can follow as far as the algorithm. So metformin is usually the first one unless we've got some kind of major contraindication. And then we're going to start adding 1 or 2 additional agents if we don't have a reduction in A1C in that first 3 months. So our goal with all medications, we want to control their A1C, but we also want to minimize their side effects. So if I'm adding in those other medications, am I getting rid of metformin? No, I'm always just adding another agent in there. So oh no, we just did that, sorry. So drug therapy, some special considerations. If it is a kid, this is going to be managed by a pediatric endocrinologist. When does pediatric endocrinology stop following their patients? 16. Usually they don't, because when it's a congenital disease, they have that understanding because it's been with them for a lifetime. So like my daughter's endocrinologist, because she's congenital hypothyroidism, because she's congenital heart disease, she actually stays with her physicians because it's not because of a disease, right? Because our treatments are always different when it's based on something versus you were born with it. So a specialty team, and a lot of times this will just stay with our patients. We can modify those glycemic targets. We are still doing insulin if they're type 1. Type 2, we're still doing metformin, and we might have to add in that insulin, but we're still recommending those lifestyle changes. So our geriatric patients, we're going to give them a little bit more leeway so that glycemic control we can actually increase by 10% for our goal. And this one we want to avoid first generation sulfonylureas and our TZDs there. We also have different ethnic groups that we need to take into consideration. Our obesity patients, metformin, our DPP4s, and our GLPs are going to also help with weight loss, which is usually a big problem. Coronary artery disease in our heart failure patients, we want to do intensive therapy with insulin because we really need to make sure that they don't get all of those micro and macrovascular complications. And these patients, we can do ACE inhibitors. What do the ACEs do? Protect the kidneys, remember? And then we're going to do aspirin. Why are we doing that? Prevent strokes. How? Because they do what? Decrease platelet aggregation. And why are we doing statins? We want to make sure those lipids are under control. Yep. So hypertension, we're doing ACEs, ARBs for nephropathy, where you talked about those ACEs. And then for neuropathy, what kind of medications can we give them? Gabapentin's a great one. And then also different tricyclic antidepressants can also be a good option.
No.
Do you want to mute every, did
I
you?
don't have access. So I'd love to,
I would love to do that for you.
Not me.
Can you mute Beth?
I've been muted, ma'am.
Okay, so we talked about diabetes is gonna be self-managed, right? We're gonna give them the knowledge, we're gonna give them the education, but they're still gonna be managing it at home. So we really need to take into account our patients' own characteristics and how they understand how they're gonna carry out their own treatment goals. So annually for these patients, we want to add in lipid testing. What are you doing a comprehensive foot exam for? Yeah, so neuropathy is huge. We obviously can't tell when they hurt themselves if they can't feel themselves, right? Dilated retinal exam, are you guys doing that? No, we're referring them out for that. We're doing microalbumin and then dental exam because we're also worried about that periodontal disease. Every 3 months, we are still bringing them in. We want documented blood pressure, A1C, foot exam, and then why are we doing a depression screening? Because it sucks to have diabetes. I think it sucks to have any chronic condition, right? Any chronic condition, we can probably add a depression screening on there and it's going to be well warranted. All right, so our type 1 diabetes, we already talked about this is only 5%. This is going to be our juvenile and this is going to be insulin dependent. Type 2 is going to be your most prevalent, 90 to 95% of all cases. Is this a repeat? I feel like this is all a repeat because we did that.
What's 2 out of the 1?
Just trying to help. I guess we're adding more stuff. Yeah.
I have a chat question.
What's up?
Is that, what about cholesterol?
What about it?
That's all I said. What about it? Where does it come from? Do you like use that to treat diabetes?
I'll have to answer that in a little bit. Maybe. I don't know if I'm going to answer that in a little bit. Okay, so we already went over how insulin works. We went over the types of insulin. So our short duration versus our short acting. So our short duration is going to be those rapid acting. We went over our short duration, intermediate. We went over our long and our ultra long. Therapeutic doses, I think we did a lot of this. Oh, I think I pulled stuff from your old book too that I liked better. I think that's why there's some duplications here. So this is showing up again. That's weird, or is it? Is it weird? This is the really big thing that I want you to have a good understanding of this chart. Maybe that's why I put it in there, so you can see.
I really don't ask this question, but I've seen Novolog and Novolog. It's the same thing?
Yeah.
Like the O.
Yes. I mean,
Because
it's,
on one part, the insulin aspart is the O and one has the A.
probably just different brands. That's the only thing that should be different. So we went over pharmacokinetics already a little bit. The big things, 2 big life-threatening things that we worry about with our diabetics. We talked about the first one that we worry about most is hypoglycemia. What's the next one? DKA. Yep. So either too much insulin or not enough food or too little insulin. Bronchospasm can occur with inhaled insulin, especially if our patients have COPD or asthma. So just keep that in mind. So pregnant women, we can use rapid or short acting insulin. It's not going to cross into the placenta. If our patient's hypothyroid, we know that slows everything down, right? Same thing with insulin breakdown. So we can have our patients with hypothyroidism might need less insulin. Just kind of makes sense with what's going on behind their diagnosis, right? So if they have hyperthyroidism, what would you expect? They're going to metabolize it quicker. We're going to probably need higher dosing of insulin. So monitoring, we're looking at glycohemoglobin. We want to look at renal function and CBC. So once they are well-controlled diabetics, we're going to do that A1C twice a year. Quarterly if they're not meeting their goals, and then point of care is going to allow them to make quicker decisions based on the foods that they're eating and what they're doing throughout the day. So how we pick what type of insulin and the amount is going to depend on what is their blood sugar, what is their daily activity. So we want to do a diet, exercise, insulin, glucose monitoring regimen. We have to take all of those things into account. We have to educate them when we're talking about the insulin. What would you want to educate them about regarding the type of insulin that they're given? How to store it? Is it important of how fast it works? Because I need to know, when do I take it before my meals, right? Do I take it 5 minutes before I eat? Do I take it 30 minutes before I eat? So they really need to know that onset, and they need to know that duration too. So a really quick, just kind of down and dirty of the pharmacodynamics of insulin is going to be important for these patients to have a good, really good understanding as far as what's going on. Type 2, so remember, these patients aren't just insulin resistant, they're not making enough endogenous insulin. We can't give them sulfonylureas because it's going to increase their insulin production. So they can have tissue insensitivity to insulin and impaired response of those beta cells, but it doesn't mean that they're completely gone. So they're still making some insulin on their own. So oral medications, some other things that we want to talk about. So excessive production of glucose by the liver. So metformin can help improve that liver response to elevated blood sugars. If we have impaired GLP-1 activity, then we can use those DPP-4 medications to slow inactivation. And then remember, all of those medications can help with weight loss. So if we do have a patient that continues to put on weight, a DPP-4 may stop it, or at least will keep their weight neutral, where metformin can actually help them lose weight. All right, so we have sulfonylureas. This is the first class of drugs developed to manage patients with type 2 diabetes. The only true oral hypoglycemics that are used for patients that still make some of their own endogenous insulin secretion. So really high risk for hypoglycemia here. And they have a limited action on insulin resistance. So when we use sulfonylureas, we're always going to use these in combination with other medications. So the first sulfonylurea we have is glipizide. Who has glipizide? Again? Bummer. Did you get your beta blocker in?
Not yet. Okay, let me pull this up. Hold on. Okay, glipizide. Trade names glucotrol. I always hear glipizide though. So sulfonate.
You speak up, please.
Yes, thank you. It's bad. Anti-diabetic. Goal reduction of blood glucose levels. The action, it stimulates insulin release from the pancreatic beta cells, reduces glucose output from the liver, and insulin sensitivity is increased at peripheral target sites. Duration of action is 12 hours for instant release, 24 hours for extended release. Side effects can be hypoglycemia, dizziness, drowsiness, nervousness, diarrhea, flatulence, weight gain. Contraindications would be hypersensitivity to glipizide and sulfonamide derivative. I can't talk today, I'm sorry, you guys. Derivatives, or any component of the formulation, type 1 diabetes, and diabetic ketoacidosis with or without coma. Precautions would be in bariatric surgery. Again, the altered absorption can happen. Use of instant release formulations after surgery to minimize the potential effects of bypassing the stomach, and proximal small bowel with gastric bypass or more rapid gastric emptying. Hypoglycemia, use an anti-diabetic agent without the potential for hypoglycemia if possible. And weight gain, evaluate risk versus benefit and consider alternative therapy. Hepatic impairment, used with caution, same with renal impairment. The G6PD deficiency, patients with this deficiency may be at an increased risk of sulfonylurea, I just can't say it, induced hemolytic anemia. However, cases have also been described in patients without that having that happen. Monitoring signs and symptoms of hypoglycemia, including fatigue, excessive hunger, sweating, confusion, blood glucose, renal function, liver function. Patient education, take the immediate release within 30 minutes prior to a meal. Extended release, take with the first meal of the day. Do not crush, chew, break, or dissolve. If you are skipping a meal, don't take the glipizide, as this can potentially cause a low blood sugar. Avoid driving till you know how it affects you. Let your doctor know if you have any allergies to sulfa drugs. Avoid drinking. If you're 65 or older, you could experience more side effects. And on the extended release, you may see the tablet shell in your stool. This is normal and not a cause for concern. That's it.
Thank you.
You're welcome. That's all I got.
All right, so next one we have is biguanides. These are oral anti-hyperglycemic drugs, so we're only using these for our type 2. Metformin is the only drug in this class that we use clinically. Who has metformin? I'm gonna make sure it wasn't you again. Before you said it.
Like, I gotta go. I'm out.
Tell me about metformin.
All right, metformin, trade name could also be Fortamed, Glucophage XR, Medsa, and Riomet, therapeutic class, biguanide. Okay, goal is available orally, used to lower blood sugar in patients with type 2 diabetes and can also used as monotherapy or in combination with other treatments. It's also being studied for potential use to manage blood sugar values in women with gestational diabetes, as well as to treat endocrine metabolic disorder associated with polycystic ovary syndrome. Mechanism of action decreases the production of glucose by the liver, slightly reduces glucose absorption in the gut, and increases the response of fat and skeletal tissue to insulin. The absorption is 50 to 60% slowly from small intestine, with therapeutic response seen within 1 week and maximal response reached within 2 weeks. Rapidly distributed into GI tract and body tissues and fluids. Metabolized, it's not metabolized. It's excreted in the urine and feces unchanged with a half-life of about 6.2 hours. Side effects are decreased appetite, nausea, diarrhea, flatulence, and rarely lactic acidosis. It interacts with calcium channel blockers, corticosteroids, thiazide diuretics, oral contraceptives, isoniazid, niacin, ACE inhibitors, beta blockers, phenothiazine, sympathomimetic agents may also alter glycemic control. It has a black box warning that it has an increased risk to cause lactic acidosis in patients of advanced age and those with renal impairment. Do not use in patients with hepatic impairment of an GFR of less than 30 milliliters per minute, or with acute or chronic metabolic acidosis, and withhold the administration in patients with conditions associated with hypoxemia, sepsis, or dehydration, or who have a history of liver disease, alcoholism, or heart failure. However, that could change. It said studies are showing that it could be used with heart failure. Anyways, precautions, it decreases the absorption of vitamin B12 and folic acid. It can make diabetic neuropathy worse. Hold metformin used temporarily with patients undergoing surgery. It's a pregnancy category B and can be used in breastfeeding women with caution. Obtain a baseline creatinine clearance in patients greater than 79 years of age before beginning metformin. Patient education, obtain a baseline renal function and periodically monitor renal function, and for patients to limit their consumption of alcohol. Metformin can cause hypoglycemia in special populations, and patients should be educated on signs and symptoms of hyper and hypoglycemia. Educate patients to adhere to planned diet and exercise regimens, and obtain baseline labs and routinely monitor plasma, CBC, and BNP.
Awesome, thank you. You guys need a break? Okay. It's 6:12. We'll try to come back 6:22.
Oh, Dr. Tyler,
Yes.
sorry about that. I think you wanted.
Okay, the second oral medication that we're gonna go into, so also for type 2 diabetes, is gonna be Preclose or Arcbose. Who has this medication?
I do, just one quick second.
Okay.
I mean, I think it's there. Let me just. Okay. Preclose, it's an alpha glucosinate inhibitor, decreases blood glucose in patients with type 2 diabetes. This slows the absorption of and digestion of carbohydrates. It is excreted in the kidney, side effects, flatulence, diarrhea, bloating. Serious side effects would be petechiae, purpura, jaundice. It's not for kids younger than 18. Precaution use with people that take birth control, niacin, diuretics, compazine. Monitor blood sugar 2 hours after taking this medication. Monitor your serum transaminase every 3 months. If the level rises, you should stop the medication. And it is very important to take this medication with the first bite of the meal. Check blood sugar daily.
That's what you got?
And do I need more?
No, I think, all right.
Okay.
So initial dose, we're gonna start with this one, is gonna be 25 milligrams 3 times per day. And this one, we're only gonna increase at intervals of 1 to 2 months. That was the only thing I would add. All right, our TZDs, because that's a lot easier to say than that other word. What we have here is Actos. Who has that medication for us? Who reluctantly said me? Oh, sorry.
Wait, I have one.
Do you have TZDs too?
No, I don't. I like-
Who has pioglitazone?
Sorry, my computer died. I had to restart it.
But you also have a healthy pancreas that is going to produce insulin in response to you eating that bag of crap. Yeah, somebody does have Actos.
We're right here, but I have done mine.
Do you have Actos too? Who has, does Beth have Actos? Beth, are you here?
Okay.
No, Beth?
I think Beth, we can't hear you. She definitely knows how to get stuff. She's okay.
Do you have a Vandia up that you can tell us about?
I'm
Evan?
sorry, my computer.
Still?
Started, so it's like.
All right, I'll go through TZDs for you. So these are going to be oral anti-hyperglycemics. So again, this is just going to be for type 2. So this is going to be for a monotherapy if a patient can't control their blood sugar with just diet alone. Or we can add them to other therapies if we've done lifestyle modifications and they're already on another anti-hyperglycemic. They're not going to be initial therapy though. So these are going to control glycemic, improve glycemic control because they're going to improve insulin sensitivity, which is a major problem in our type 2s. So this is going to be dependent on the presence of insulin for their action, which is why this is only for our type 2s. So this is going to be highly selective for certain activators, and we have to see expression on certain proteins to improve insulin action that's already occurring in these patients. So these medications are going to be rapidly absorbed after oral administration. Food is not going to alter that absorption, but it does delay the time until that peak concentration is going to be achieved. These drugs are going to be highly metabolized by the liver into the metabolites. So precautions, the metabolites of these drugs have been found to increase concentrations in patients with chronic liver disease. Makes sense, right? Our liver has to break down drugs. Your liver doesn't work, doesn't really break down the drug. So what are you going to check more often? Liver function. So I'm going to do that actually before I start therapy and then frequently during therapy. So if I have an ALT that is higher, greater than 2.5 times the upper limit of normal, what do you want to do with the drug? I'm going to discontinue it. These are going to be generally well tolerated. Generally well tolerated. They do have some cardiovascular effects. Weight gain can happen in about 5% of patients, hypertension in 4%, heart failure in 2%. We have seen 3% of patients develop myocardial ischemia. We can see increases in total cholesterol, HDL, LDL, and weight gain. That's going to occur in about 10% of the patients. This will interact with oral contraceptives that contain ethinyl estradiol or norethindrone. It's going to reduce plasma concentrations of both by 30%. So who would you want to tell to be cautious? Women of childbearing ages, if you don't want to become pregnant, because this is going to make your birth control not as effective by 30%. I'm probably not taking those odds. What would you, if it decreases the efficacy by 30%, what do you have to do to your dosages? We'd actually have to increase the oral contraception, yeah. So we already said we are going to monitor ALT at the start of therapy. If ALT is greater than 2.5 upper normal, we're going to discontinue. Once we start therapy, we're going to check ALT every 2 months for the first 12 months and then just periodically thereafter. If ALT increases to more than 1.5 to 2 of the upper limits, liver function tests are going to be done every week until those liver tests go back to normal. If we get to 3 times upper normal limits, then we are going to discontinue the medication. If I'm starting you on a medication and you have to have your blood drawn every 2 weeks, what implication does that have with our patient? It's a bad medication. That costs a lot. Every time I go to the lab, if I have to pay for it, and if you're adjusting my doses every 2 weeks, I have to pay for it. So this can be something that's very costly to our patients. So we have to keep that in mind.
Not only cost, but I would also say that they would get to the office.
Yep, transportation is going to be huge too. Yeah. Yep. Okay, next we have meglitinides. So we have natglinide as our education one. Who has that? Yeah, tell me about it.
Endocrine, I think you've mentioned, you pronounced it, so I know how to pronounce it. Also known as Starlix. The goal is it's an oral anti-hyperglycemic agent used for treating non-insulin dependent diabetes mellitus in conjunction with diet and exercise. The goal, actually it stimulates pancreatic islet beta cell insulin release. Natglinide is readily absorbed and metabolized in liver. Its onset is within 20 minutes, has a peak plasma concentration within an hour, lasts 4 hours, and a bioavailability of approximately 73%. About 83% of it is excreted through the urine, and the remaining through stool, and has a half-life of 1.5 hours. Side effects are common ones are upper respiratory infection, back pain, influenza-like symptoms, dizziness, arthropathy, diarrhea, bronchitis, cough, and hypoglycemia. Serious side effects are hypoglycemia, hypersensitivity, and cholestatic hepatitis. Contraindications: type 1 diabetes, and then diabetic ketoacidosis. Precautions: in pregnancy, breastfeeding, impaired renal function, impaired hepatic function, malnutrition, adrenal insufficiency, autonomic neuropathy, elderly patients. We want to monitor creatinine and estimated GFR. Patient indication to take medication now, typically 3 times a day within 30 minutes before meals. If you skip a meal, do not take a dose until your next meal. You may experience hypoglycemia and feel hungry, dizzy, irritable, confused, anxious, or shaky. If this occurs, eat or drink fruit juice, hard candy, cracker, raisins. If you are not able to resolve hypoglycemia or have a severe reaction such as hives, difficulty breathing, swelling of face, lips, and tongue or throat, seek emergent medical care. And then let's see here. Oh, and this medication has also been known to cause weight gain.
Okay, so your meglitinides, these are really just for patients with postprandial hyperglycemia. So if they have got an A1C less than 8, we're just starting at 0.5 milligrams before each meal. Greater than 8, then we're going to do 1 milligram. So this is another one we're just going to increase very slowly. So we can double the dose, but we're going to wait for 2 weeks and we're going to max out at that 16 milligrams. Okay, now we have our gliptins. These are our DP4 inhibitors. So the one that we have here is Januvia. Who has Januvia?
Training Januvia therapy class is the delta phase 4 inhibitors. The goal is to match IP diabetes mellitus. Action inhibits
DPP4.
DPP4, there you go. Slowing incretin metabolism, increasing insulin synthesis, release, and increasing gluten. Absorption after oral administration of 100 milligrams dose. It was rapidly absorbed with peak plasma concentration occurring 1 to 4 hours post-dose. Distribution of following 100 milligrams intravenous Juvia in healthy patients, approximately 198 liters. Metabolism and elimination. The dose was 16% radioactivity excreted as metabolized. 6 metabolites were detected, and the levels in the plasma of DPP4 inhibitory activity is detected. In vitro studies indicated that the primary enzyme responsible for the limited metabolism was the CYP3A4 with contributions from CYP2CA in elimination. Approximately 7% of cyclin is excreted unchanged in the urine. The half-life was 12.4 hours. Side effects: upset stomach, diarrhea, stomach pain, upper respiratory infections, stuffy runny nose, sore throat, headaches, constipation, history of serious hypersensitivity reaction, such as anaphylaxis or angioedema, type 1 diabetes in children under 18 years of age. Precautions: acute renal failure, history of pancreatitis, heart failure risk, hypersensitivity reactions, severe and disabling heart allergy, and bolus big boy. Monitoring the GFR at baseline and glucose levels, patient education, take media once a day as prescribed by your provider. Okay to take with or without food. Also monitor or take in combination with diet and exercise, careful monitoring of the glucose.
Good. She's like, yes. Okay. No, you were good. Yeah.
I am not gonna, I'm just gonna say, I have no idea. If there's like a chart that says, okay, we did this, Metform's the first one, then how the hell do I know what's the next one I start? Like,
You're gonna follow your algorithms. So yeah, if we go to the if we go to the ADA, there is going to be an algorithm for you guys. And then as you practice, you're going to develop your own algorithm. So we all tend to find the medications that we like. So when I say that I find the medications that I like, what makes me like a medication?
good results from this.
Yeah, so I like medications that I can know what to expect both from the outcome. I know what the big side effects are. So I can do really good patient education, and obviously the ones that are effective, right? So you will find your own algorithm as far as, you know, we just talked about DPP4s. There's a bunch of them. So there's going to be the ones that you're going to get feedback from patients like, man, I had to do, or my MA has to do a prior authorization on this one. I still can't get it covered. It's only covered with commercial insurance, or I had a drug rep come in yesterday, and this always makes me irritated. So they just came out with another oxycodone that has a abuse deterrent in it. Great in theory, right? But each pill costs about $20. So it's going to cost your insurance $1,000 to fill it. What does that do to healthcare costs? Increases it for everybody, right? And they're like, well, commercial insurance, it's covered. Well, yeah, because commercial insurance has to pay that $1,000. So everybody's healthcare costs go up. So is it a good thing for me to go to that drug? And I unfortunately have the inability to bullshit. So I tell the drug rep, like, I'm never going to prescribe this. Number one, it's so much work for my MA. Yes, it's great. In theory, every drug should have an abuse deterrent, but not every patient is going to abuse it. And if you're going to abuse a medication, they're usually going to find a way. So I'm not going to charge an insurance $1,000. That one's going to fall off my algorithm. Not fall off. It never made it on. So you're going to develop your own algorithm once you start becoming comfortable with medications. When I do neuropathy, I have my own algorithm. Like, I always start with What's a big one for neuropathy? I start with gabapentin. It's old, it's cheap, and it's generic. I know what side effects to expect, so I can tell you about them. I know most of those side effects are going to resolve on their own. So that's going to be number one on my algorithm. And then if that fails, I go to Lyrica because now that's generic. If that doesn't work, I go to Topamax. I keep Topamax as my third runner-up because the side effects are abundant in that one and everybody develops one. So I just have my own algorithms after doing this for a lot of years. You guys are going to have the same thing once you get into practice. You might just develop the algorithm from whoever you train with because, hey, they've already done all of the research. They've put in the time and the hard work, steal their algorithms. But otherwise, you're going to be able to go into ADA guidelines and find out what your diabetic algorithm is. You're going to go to the American Heart Association and get your hypertension algorithm. Antibiotics, luckily we have great algorithms for that one. So this isn't anything that you're going to have to guess. You'll get one and then you'll develop it and make it specific to you.
So how being tested on it, are we just needing to know like what the target therapy is?
Yeah, I need you to know your big things. So medications that have black box warnings, know those. Know if something is going to be for a type 1 or a type 2. Know if something's going to be a monotherapy or not. So we can really overgeneralize when we're in pharmacology right now, and then we'll specific everything once we get into practice. So I want you to overgeneralize everything. And that's why I just give you a drug in that class because they're all going to be more similar than they are different. Did that help?
It did.
Okay.
I just feel like I'm like,
There's like a whole chart on this website of like following.
I just looked.
Yes, and you do, you will, you'll just follow the arrows. And new grads, especially in primary care, you guys on your desks will have an antibiotic chart.
Oh, yeah.
If this, then that. If they're allergic to that, then this. And it just has arrows. And so one of the things too, you guys always want to know, like, well, I don't want to look like I don't know what I'm doing with my patient, right? But in the room, do we ever have to say like, well, I'm going to start you on this type of antibiotic? No, we can just say, well, I'm going to start you on an antibiotic and I want you to come back if symptoms haven't improved or resolved in 7 days. And then I can go look at my chart and send in the antibiotic, right? So our patients don't need to know those specifics if we don't know them right then and there. That's totally fine. And even if you're unsure of what you're going to do right there in the room, I promise you still know more than they do. So we can probably fake it just fine, okay? All right, next we have glucagon-like peptide 1 agonists or GLP-1s. This is another one that is going to be for our type 2. Who has Byetta? Tell me about Byetta.
Exenatide or Byetta or Idurian. Mechanism of action, it's an analog of the hormone incretin, which increases glucose-dependent insulin secretions, decreases inappropriate glucagon secretion, increases B cell growth / replication, slow gastric emptying, and decreases food intake. It says administration results in a decrease in A1C by approximately 0.5 to 1% in the immediate release, or 1.5 to 1.9% in the extended release. As far as the metabolism, it says it's minimal systemic metabolism. Proteolytic degradation may occur following glomerular filtration. It's mostly excreted in the urine. Side effects include diarrhea, constipation, nausea, vomiting, fatigue, antibody development, injection site nodule, injection site reaction, hypoglycemia. It says may cause cholelithiasis or cholecystitis, pancreatitis, may exacerbate renal failure, and then also thrombocytopenia. Has a black box warning for the Bydureon for thyroid C cell tumors. Have developed in animal studies. Unknown if it causes these tumors in humans. Contraindicated in hypersensitivity, end-stage renal disease, diabetic ketoacidosis, personal or family history of medullary thyroid cancer, and multiple endocrine neoplasia syndrome type 2. Precautions: renal impairment, gastroparesis, patients planning to become pregnant just because there are other agents that are preferred. For monitoring serum glucose, renal function, volume status, weight, triglycerides, and then signs, symptoms of pancreatitis or gallbladder disease. As far as education, how to administer subcutaneous symptoms of thyroid tumors, and to give it within 60 minutes before the morning and evening meals, and that the doses are at least 6 hours apart. Store any unopened pens in the refrigerator.
All right, so this one we have extended release that the patients can do in weekly injections, which is a nice benefit for them. This is going to work well for or better than rapid release on A1C and weights, but GI issues that do happen, they're often going to be transient. So kind of hard of when to tell our patients that they can expect those to happen. Okay, next we have glucagon. So we know glucagon is a hormone that's secreted by what organ? Also the pancreas. So primary use clinically is in elevated blood glucose levels during a hypoglycemic episode. So who has glucagon?
I do.
Again? Man.
No. It is a glucose elevating agent, a hormone that increases blood sugar level. It's also used to stop GI motility during radiological exams to determine certain disorders of the stomach or intestines. When glucagon binds to glucagon receptors, it activates GSA and GQ, which then activates adenylyl cyclase that increases intracellular cyclic AMP and activates protein kinase A. When GQ is activated, also activates phospholipase C, which increases production of inositol 1,4,5-triphosphate and releases intracellular calcium. When protein kinase A attaches phosphate groups to glycogen, it causes it to break down. Essentially, it prompts liver glycogen breakdown and glucose release and relaxes GI smooth muscle. It is metabolized in liver, kidney, and plasma, has a half-life of 8 to 18 minutes when given IV and 45 minutes if intramuscular. It is unknown how it is excreted. Common side effects are nausea, vomiting, swelling at injection site. More severe side effects may include redness at site of injection, itching, blistering, crusting, scaling, or other skin lesions. This is contracted if a person did not eat, is passing out, having a seizure, allergic to any ingredients, have tumors of the pancreas or adrenal glands, chronic hypoglycemia, or breastfeeding. Use precaution people with alcohol consumption, prolonged fasting, starvation, adrenal insufficiency, or cardiac disease. Monitor blood glucose. For patient education, glucagon injection should be given as quickly as possible to hypoglycemia. Glucagon is injected under the skin and show muscle or vein. You will need to provide proper education to the patient. You'll need to contact your healthcare provider each time you use a glucagon injection. After the injection, you should eat a fast-acting source of sugar, such as juice, glucose gel, hard candy, raisins, or non-diet pop, and then a small meal such as cheese or crackers, or a small meat sandwich. If low blood sugar is not resolved in 50 minutes, you may need another dose. If low blood sugar continues, seek emergency medical care. Note that stress, illness, exercise, alcohol use, or skipping meals may affect your blood glucose levels. Glucagon should be stored at room temperature, away from moisture, heat, and light. Do not freeze or refrigerate. Discard any mixed medication that was not used right away, and do not use any expired medication.
So glucagon, we're just doing for reversal of hypoglycemia. That's our clinical indication for this one. We need to have the presence of glycogen in the liver. If I'm starving myself, do I have any glycogen stores?
No.
So is glucagon going to do anything? It will not even work. So if we have a patient in a starvation state, if we have an anorexic patient, glucagon is not going to reverse any kind of hypoglycemic state. Same thing if they have adrenal insufficiency or just chronic hypoglycemia. They don't have glycogen stores in the liver. Glucagon's not going to do anything for them. That was a lot, huh?
Yeah.
I feel like we probably should have waited for our break to at least get through that, because it was a lot. Okay, now we're going to go through thyroid. Does anybody in here love endocrine? You like endocrine? I like endocrine a lot because I think it's very easy to figure out what's going on, because the endocrine system works on what kind of system? Negative feedback, right? If this doesn't work, then that's not going to work. So I know if this is elevated, the thing behind it's not working. That's why I kind of like endocrine. It's kind of easy to trace back and see what's going on. So all of our thyroid hormones that we need to talk about, these are going to have a big effect on metabolism. They affect our cardiac function. How a patient grows and develops is all going to be stimulated by these. Hormones are going to stimulate our metabolic rate of almost all of our cells. Even the force and rate of contraction of my heart is going to be mandated by these. So in infancy and childhood, our thyroid hormones, this is what's going to promote our patients to mature. So if I have severe deficiency in any of these hormones, what would I expect my patient to look like? Small in stature. Are we going to have good metabolism where we burn off fats? So what would they look like? Small in stature and overweight. What does their brain development look like? Probably mentally slow as well, right? So this is what we were talking about with the negative feedback system. So this is all regulation of the thyroid function. So we've got TRH, which is thyrotropin releasing hormone from the hypothalamus. That is going to stimulate release of TSH, thyroid stimulating hormone, from the pituitary. TSH is going to stimulate all aspects of our thyroid function, including T3 and T4. T4 is then going to act on the pituitary to suppress TSH in that negative feedback system. So when we're doing function testing for the thyroid, the first thing that we look at is serum thyroid stimulating hormone. So TSH, that's the biggest thing that we're going to use when we want to screen and diagnose patients with hypothyroidism. This is also how we're going to monitor patients when we are giving them thyroid replacement medications. So your TSH is going to be the most sensitive method for diagnosing hypothyroidism. And that is going to be that TSH is made where? What organ? Pituitary, but which anterior pituitary? Anterior or posterior? Anterior pituitary. Feel like that's important. This is the anterior pituitary is very sensitive to any kind of change in thyroid hormone levels. So even just a small fluctuation in T3 or T4 is going to make TSH change in response to that. So just a tiny drop in T4, tiny elevation is going to cause a huge drop or elevation in TSH. So TSH is going to be a really sensitive one. Your thyroxine test. So this is your total T4. So T4, or if we are measuring T4, we want the preferred method is going to be your free T4. So this is how we monitor thyroid hormone replacement therapy or to screen for thyroid dysfunction. But remember, it's not going to be as sensitive as TSH. So it's going to help with diagnosis, but we prefer the TSH. With T4, we can also measure total or free T3. Free T3 is going to be the preferred one that we want to look at. Also, this is going to be helpful with diagnosing hyperthyroidism. So T3 will often go up sooner than T4. So it's going to be a little bit more specific and sensitive. So we're also going to use that one when we're monitoring replacement therapy. So thyroid hormones that we give to our patients, these are now available as pure synthetic compounds. So we actually extract these from animal thyroid glands. So it's made from another body and put into our body. So all of these preparations are going to be more similar than they are different. So first one, or to talk about the T4, so levothyroxine, we have Synthroid is going to be our prototype. Who has Synthroid?
I do. So the goal is to replace its replacement of hypothyroidism to restore hormonal balance and suppression of thyroid cancer. It acts by replacing or supplementing the endogenous thyroid hormone. The principal effect is increasing the metabolic rate of body tissues, promoting gluconeogenesis, increasing utilization and mobilization of glycogen stores, stimulating protein synthesis, promotes cell growth and differentiation, and aids in development of the brain and CNS. It's variably absorbed in the GI tract by 40 to 80%, distributed to most body tissues, 99% protein bound, metabolized by the liver and other tissues to active T3. Thyroid hormone undergoes enterohepatic recirculation and is excreted in the feces via bile. Half-life is 7 days. Side effects include headache, insomnia, irritability, angina, arrhythmias, tachycardia, cramps, diarrhea, vomiting, sweating, menstrual irregularities, heat intolerance, weight loss, accelerated bone maturation, and children. It is contraindicated in hypersensitivity, who had a recent MI or already hypothyroid. Used cautiously in cardiovascular disease, severe renal insufficiency, uncorrected adrenocortical disorders. In kids, you want to monitor for cardiac overload and aspiration during the first 2 weeks of therapy. And then in your geriatric population, they're super sensitive to hormones, so they think that those should decrease. It interacts with bile acid sequestrants, warfarin, insulin, oral hypoglycemic agents, estrogens, and then like adrenergics, and then foods containing calcium, iron, magnesium, or zinc may bind to the levothyroxine and prevent complete absorption. You want to monitor blood pressure, pulse, ECG, and like assess for tachyarrhythmias and chest pain in children. For you want to watch for their height, weight, psychomotor development. Check thyroid function studies, blood and urine glucose in diabetic patients. And then watch for toxicity and overdose, which is manifested as hyperthyroidism, tachycardia, chest pain, nervousness, weight loss tremors. Patient education includes taking it at the same time every day before breakfast, taking out water only on an stomach, waiting 30 minutes to 1 hour before eating or drinking anything other than water. It is lifelong therapy. They need yearly follow-up exams within an ideal range. And then advise them to notify the healthcare provider if signs or symptoms of toxicity or weight loss greater than 2 pounds or a week occur.
So our takeaway with levothyroxine, just like I think most medications we've talked about, we are going to start low and go slow. So we don't want to increase their metabolism too much too fast. We need their body to adapt to the changes that the medication is going to cause. So we start it usually at 50 mics daily, and we're just going to do 25 microgram increment increases. And we're only going to do these about every 2 to 4 weeks. So target goal, we want our TSH level to be approximately 1.7, and it's a microgram per kilogram per day. So usually our older adults are going to require less than 1 microgram per kilogram per day as their target. So
Interestingly, my sister as a pharmacist said that if you start on the brand, you're stuck on the brand. It's such a narrow therapeutic. So like if you start, you usually want to try to start on generic. Because once they go brand, they
once you go brand, you never go back.
I thought that was really interesting.
That is interesting, and I did not know that.
Yeah, so don't start brand.
Okay, so rational drug selection, we want levothyroxine. Non-brand is what we want to do, is we want to do generic. Okay, then we have antithyroid agents, or PTU is the drug here. So this is when we want to inhibit the thyroid hormone or destroy thyroid gland tissue. Who's got PTU?
And I'm not going to say the generic thing. I don't know how to say that.
I always want a pharmacist to sit out on my class to see how bad I butcher these, because I would too, but PTU is fine by us.
PTU. It is an anti-thyroid agent. It is a treatment of hyperthyroidism in patients with Graves' disease or toxic multinodular goiter who are intolerant to the other one. Methimazole. I don't know how to say that either. Sorry. It says it is also off-label use for internal contamination with radioactive iodine or thyroid storm or thyrotoxicity. It inhibits the synthesis of thyroid hormones by interfering with thyroid, I'm going to say TPO, it's paradoxis, which oxidizes iodine. I'm going to go to your slide really quick. It says it blocks synthesis of thyroxine or T3. Let's see. So onset for significant therapeutic effect is 24 to 36 hours, which is required. Remission of hyperthyroidism usually does not occur before 4 months of continued therapy. Duration is 12 to 24 hours. It is protein binding 80 to 85%. Metabolism is hepatic,
Bioavailability is 53 to 88%. The half-life elimination is 1 hour. Time to peak is 1 to 2 hours. And it is excreted in the urine. Side effects can be skin rash, nausea, vomiting, epigastric distress, headache, drowsiness, vertigo, edema, and jaundice. Serious side effects, liver injury, liver failure, requiring liver transplant or resulting in death. It was very specific as far as the liver injury with this drug. It is contradicted in anyone who does currently have liver issues, liver transplants, not recommended for children. PTU does cross the placenta and cause fetal goiters. So it's got a pregnancy category D. It can cause, where is that? Monitoring, you need to monitor signs and symptoms of illness, fever, sore throat, skin erosions, general malaise. You want to monitor their CBC, you want to get a baseline, and if the development of febrile illness, monitor their PT, LFTs, ALT, AST, and then thyroid test. Patient education, administer, it is very important to not miss a dose of this medication. If you do miss a dose, you are not to make it back up. If you become pregnant while taking this medication, you need to let your doctor know right away. If you are going to have any type of surgery or other medical conditions, let them know prior to starting this medication. Tell your doctor if you are breastfeeding, because it does cross into the breast milk. And drug-to-drug interactions can happen, especially with lithium and then warfarin. And blood pressure medications such as metoprolol and digoxin.
All right, so kind of like our diabetic patients, if you have a post-hyperthyroid treatment, you need to let your patients know that if they do have hyperthyroidism, if they do have a goiter, this is going to be a lifelong treatment. This is a chronic illness, and they have to be the ones to really self-monitor to know, is everything going well or going poorly? So they need to know symptoms to look for as far as drug therapy, to know if things are working the way that they're supposed to. So part of that is making sure that they are making those follow-up appointments and attending them, because we have to evaluate that thyroid function. This is going to be really important in our kids too, because that thyroid is hugely important in both psychosocial, motor skills, physical, everything. All of that development is going to be dependent on the thyroid. So kids are going to be especially important. All right, then we have estrogens and progesterones. So we're going to use these for a variety of conditions. What's the main one that we'll use it in primary care? Contraceptive, yeah. So estrogens and progesterones or progestogens are hormones with a couple of different actions. For females, they are going to promote maturation. They're going to help regulate ongoing female reproductive organ activity. They also help with bone mineralization and lipid metabolism. So the principal endogenous estrogen that we produce is estradiol. The principal endogenous progestational hormone is progesterone. So both of those are going to be made where? In the ovaries. So if I have somebody that they take out their ovaries, what are they not getting anymore? They're not making any of those endogenous hormones anymore. During pregnancy, we're going to see large amounts that are going to be produced by the placenta. Small amounts of estrogens and progesterones are going to be produced in the peripheral tissues, but nothing like what is produced in the ovaries. So medications that we have here, we have estrogens. So for females in our premenopausal women, the ovary is the principal source of us getting estrogen. So we've got that follicular phase of the menstrual cycle where estrogens are going to be made by the ovarian follicles. During the luteal phase, estrogens are going to be synthesized by the corpus luteum. During pregnancy, we're going to see big quantities of estrogens produced by what? The placenta. Excretion of those is going to be in the urine, so we will see high levels of estrogen in the urine. For males, estrogen production is also going to happen in the human male. Small amounts of testosterone are going to be converted into estradiol and estradiol by the testes. Like all of our other steroidal hormones, estrogen is going to act primarily through receptors in the cell nucleus, not on the cell surface. So estrogens are going to be important for female reproductive and for secondary sex characteristics. So we need those for both growth and maturation of uterus, vagina, the fallopian tubes, and the breasts. We know estrogen also has a positive effect on bone mass. So under normal conditions, the bone is going to continuously remodel. So bone mineral is going to be absorbed and deposited in equal amounts. Estrogen is going to block bone resorption. For cardiovascular effects, less common in our premenopausal population as to our postmenopausal. So estrogens do have several roles in lowering the risk of cardiovascular effects. They also have effect on blood coagulation. So estrogen is going to promote and suppress blood coagulation. They have effect on our central nervous system. So we have a neuroprotective effect because it's going to defend our neurons from oxidative stress and injury. They also help with glucose homeostasis. So estrogen is pretty important, right? We just talked about almost every body system that they are going to play a part in. All right, so we have phytoestrogens. These are plant-based compounds that are very weak in their estrogenic activity. There's 3 different types here. Most common is phyestrin is isoflavones, which are derived from soybeans and red clover. So a lot of women will use these as a natural way to help with symptoms that they experience from menopause. Then we have SERMs. These are selective estrogen receptor modulators. So these are going to activate tissues to block out estrogen. So these were developed to hopefully provide benefits of estrogen while avoiding drawbacks. So estrogen can cause what kind of cancer? Breast cancer, even uterine cancer, and also at a risk for developing DVT or PE. So we've got 4 different SERMs that are available in the US. None of them are going to have all of the benefits of estrogen, and none are going to avoid all of the drawbacks. So we don't really have one that we're going to pick over the other. Progestins. So often we're going to do estrogen and progestin together. Remember, progesterone is the main endogenous progestational hormone. So as the name implies, it's going to act before gestation to prepare the uterus for implantation of a fertilized ovum. It's also going to help maintain the uterus throughout pregnancy. Hormone replacement therapy, or HRT. So sometimes you'll hear it called menopausal hormonal therapy. So this is when we do low dose estrogen with or without progesterone to compensate for the loss of estrogen that happens during menopause. Then we also have drug therapy for transgender women. So a transgender woman is a woman who is phenotypically a male, so born with male sex organs, but internal experience is that as that of a woman. So to help promote those sexual characteristics to match their gender identity, we would have to do hormonal therapy. So treatment for transgender women, we would have to decrease testosterone levels and also increase estrogen levels to get those secondary sex characteristics. So overview of these, we did already talk a little bit about the normal menstrual cycle, the mechanisms of how we get pregnancy prevention we're going to go over, and then what are our goals of treatment, along with how do we pick what drug. So normal physiology. So this is going to be positive and negative feedback systems. So hypothalamic pituitary ovarian axis, or the HPA, you'll see it referred to as what controls this. So we've got those gonadotropin releasing hormones that are going to regulate FSH, which are your follicle stimulating hormones, and our LH, which is luteinizing hormone. So that's going to help regulate the secretion of both estrogen and progesterone. So menstrual cycle is going to be divided into 4 phases. We've got our follicular, our ovulatory, our luteal, and then our menstrual. So during that follicular phase, FSH is going to stimulate follicles to develop. then it is going to make enough estradiol to cause a negative feedback and decrease that FSH level. During the ovulatory phase, those estradiol levels are peaking, and we've got a positive feedback to induce that luteal stage. Estrogen is going to cause proliferation of the endometrium and development of progesterone. During that luteal phase, we're going to have progesterone stop any new follicle development from occurring. If there's no pregnancy that occurs during that time, then the corpus luteum is going to degenerate. It's going to shed its lining, and then we will experience menstrual bleeding. So we said estrogen has that positive effect on bone mass. It also is going to help increase triglycerides. It improves our HDL and our LDL. It stimulates that coagulation pathway and increases body temperature and insulin levels. We also know it can depress the central nervous system. So we've got two formulations of estrogen that are going to be available for contraception. They're going to be ethinyl estradiol and menstrual. So first generation progesterone that we have is norethindrone. Who has that one?
Norethindrone has a lot of kinases. The action is, it says net is used in preparations for progesterone-only contraception, suppresses ovulation, thickens cervical mucus, which inhibits sperm penetration, alters follicle-stimulating hormone and luteinizing hormone concentrations, slows the movement of the ovum through the fallopian tubes, and alters the endometrium. It is given orally and rapidly absorbed. Says as far as protein binding, it's 61% to albumin, 36% to sex hormone binding globulin. Bioavailability is 64%. It's excreted. It's greater than 50% as metabolites in the urine, and then feces is 20 to 40%. Side effects include bronchus formation, depression, dizziness, fatigue, headache, insomnia, emotional liability, acne vulgaris, alopecia, plasma, pruritus, amenorrhea, hirsutism, hypermenorrhea, weight gain, abdominal pain, nausea, vomiting, breakthrough leaking, breast hypertrophy, breast tenderness, cervical erosion, change in cervical secretions, abnormal hepatic function, and optic neuritis. It's contraindicated in hypersensitivity, pregnancy, breast cancer, undiagnosed abnormal genital bleeding, benign or malignant liver tumors, any history of DVT or PE, arterial thrombolytic disease, and hepatic disease. Monitoring pregnancy status, weight, potential health status changes, vision changes, depression, lipid profile, and glycemic control in diabetics. As far as patient education, it says smoking while using this medication raises the chance of severe heart and blood related side effects. If diabetic, monitor blood sugars closely. Perform regular breast exams and gynecologic checkups. Certain drugs, herbal products, and health problems may cause this medication not to work as well. So make sure that you tell your healthcare provider about everything you're taking. And it does not stop the spread of diseases like HIV, hepatitis, or other STIs.
All right, so let's talk a little bit more about birth control. What if I am morally against birth control? Too bad. Does that matter when I'm in a patient's room?
Oh,
Well, if the patient's against it, then we'll want to know that. Yeah, we'll want to talk about it. So if morally I'm against birth control, but
I think you can there's a clause that you can.
No, you're not subject to all the ways onto the patient.
No, there is a
You're
law.
gonna
You
project
can't
you
do
with
it
friends,
refer out
say,
to somebody
you
who
have to
prefers
give them the
option to go somewhere else.
I love that this already started to debate. This is awesome. Okay.
Working clinic with a provider who is definitely on like the, like, would not prescribe any birth control to his patients.
So what did he do instead?
Either if they are interested in like the, whatever family thing that they, whatever, he would teach them that, or else he referred them to another provider.
Okay. So we can have our beliefs and we can choose to maybe not prescribe birth controls, but we cannot put that belief on another patient and make that belief theirs. So I could stand by a moral code of, yes, I'm not going to prescribe birth control, but that means I need to give you to a provider that will, if that's what you choose. You never need to know my beliefs as a provider. That has no place when I'm talking to my patient as far as what we're talking about. When I'm finding out what you want to do and what your beliefs are, that is fully centered around you. What are you looking to do? What are your beliefs? What options do you want to choose for you? And if you say, I want birth control, I don't tell you, well, I don't believe in birth control. I can say, great, I'm going to get you with a provider that's very well educated on birth control so you can speak to them. There's no reason for me to ever tell you any of my moral beliefs when we're talking about birth control or anything along those matters. So when we're talking about birth control, we're talking about anything that can interfere with the birthing or the reproductive process, right? So pharmacologically, we're going to talk about oral contraceptives. There's also implants we're going to talk about. There's injectables, there's intrauterine devices, there's even transdermal patches. So when we're doing anything birth control, we're interfering with that reproductive process anywhere from the gametogenesis to nidation, which is when we actually have the implantation of the ovum. So pharmacologically, the best method of contraception, most frequently, what is the best way we can prevent pregnancy? Method of contraception. You're gonna have sex. How do I stop contraception? What's the best method?
No.
Condom?
Not condom, either.
I saw the dirt.
She's like, welcome to my baby. So
It was like 80%. I could not believe it.
sterilization is going to be the best way for us to ensure that no or the best contraception that we have. So for female sterilization, we've got tubal ligation. Male sterilization, we've got vasectomy. These are going to be selected 19% of the time when we're figuring out a birth control method. This is also a point of contention. So what if you have a 24-year-old female come into your office saying, I don't want to have kids, I want my tubes tied. We're not obese, so we don't have to sterilize them. There are going to be certain doctors that will not sterilize somebody just specific to their age. I think that's wrong. I think a patient should be able to do whatever a patient wants to do, because if they make that choice, then they're the ones that are going to have to deal with it, not the doctor. Again, that's putting your beliefs that, oh, a woman is supposed to be a mother and she's going to choose to have a baby later on. You're putting that belief on her by saying, no, I'm not going to sterilize you just based on your age.
But that's why I would go and say, like, psychology, like, just like they do with, to make sure that they are.
So you want a psych eval to make sure that she is of sound decision making?
No, I think it would be at a right decision, it would need to be like at least a couple of appointments with the surgeon to make
And-
sure that this is like well thought out and not an abrupt decision.
So and family care, when they come to us and they're saying, I'm 24 and I want to be sterilized, what is our job right now?
Go see what OBGYN.
So we're going to refer them. Is this a good opportunity to educate? So you just tell them the pros, the cons, right? That sterilization is a permanent effect. They have to make sure that they understand what they're going into. And as long as we do our education, we can certainly refer them out for that sterilization. Your job is just the education, just the informing, no judgment, no whatever your beliefs are. So after sterilization, we've got diaphragms, we've got periodic abstinence, that one never works, IUDs, and then other techniques which account for a small fraction of birth control use. So several factors we want to consider when we're deciding what type of birth control we're going to use. So if I'm trying to talk to my patient about what method does she want to prevent pregnancy, what's my number one thing that I'm going to look at when I pick?
Compliance, yeah.
Compliance is a big one. So for a medication to be effective, they have to be compliant. So that's my number one thing I want to look at is effectiveness of the medication or the treatment. What question did you have?
The book said another thing to consider is how often they're gonna have sex. Because if it's super often, then they should be like on pills, but if it's like, like once a month.
Yeah, so that's gonna fall into effectiveness, isn't it? So if I take a birth control pill every time, if I'm only saving it for when I have sex, that's not gonna be as effective, right? Whereas if I'm having sex routinely, I wanna take a birth control every single day, so I make sure that I don't have any implantation. So it's gonna kind of speak to effectiveness. Second thing we wanna look at is the safety of whatever medication or whatever procedure we're recommending to our patient. And then we want them to let us know what is their personal preference. That's gonna be the third thing that we look at. So the two main categories of oral contraceptives, we've got the main one that is estrogen plus progesterone. So that's gonna be your combination oral contraceptives, or we're gonna have those that are just progestin. These are gonna be known as mini pills or progestin only oral contraceptives. Of the two, the combination is gonna be the most widely prescribed and the most widely used. So your oral combination contraceptives have been around since the 50s. They're one of the biggest family of drugs that is prescribed. They are both safe and effective. They have pretty minor side effects as far as how they affect women. So we already talked about our first generation. So this one's gonna have a lower risk for thrombosis than with other progesterones. Second generation, a little bit higher risk for thrombosis, more so than those first generation. Third generation are gonna be the greatest risk for thrombosis. And then fourth generation, greatest risk for thrombosis. So some adverse effects. We can see all kinds of things happen. Severe effects are very rare. So compared to the serious risks associated with pregnancy and childbirth, these are very minor. So oral contraceptives, we want our main patient that's going to be taking these, we want them to be healthy, normal functioning women. When they're healthy, just at their baseline, their side effect profile is going to be much, much less. Even so, we want to try to minimize those risks. So in order for me to make sure that none of these things happen, what should I do a really good part of my, I'm trying to not say the word. I should do a really good assessment. What word do you want to? I want to do a really good history, right? So we need to talk to our patients. So we need to figure out what is a relative contraindication versus this is just something that should be used with caution. Because we can see all kinds of thrombolytic events. We can cause hypertension. Some of these even cause cancer. So we do know that oral contraceptives are going to decrease the risk for several disorders, including ovarian cancer, endometrial cancer, ovarian cysts, PID, benign breast disease, iron deficiency anemia, and even acne. So oral contraceptives are also going to affect menstrual symptoms. So cramps are generally reduced. Menstrual flow is often reduced in both volume and duration, and it makes menses more predictable. If you have premenstrual disorder or premenstrual dysphoric disorder, oral contraceptives can reduce the symptom intensity. If they have menstrual associated migraines, it can actually reduce migraine frequency. It even gives benefit to women that have rheumatoid arthritis. So are we always only prescribing oral contraceptives to prevent pregnancy? I just gave you a whole list of other reasons that patients might come to us asking for these oral contraceptives. So progesterones, these are going to be primarily responsible for that contraceptive effect. They are going to work on the negative feedback of that HPA axis by acting on the endometrium and causing atrophy. So this will prevent implantation. It does improve efficacy by suppressing that follicle stimulating hormone release, and it's going to provide more cycle control. So our treatment goals with this, we want the safest, best tolerated, and most effective medication that the patient desires. So in order to do this, we have to also know about any kind of cultural or religious determinants, as well as the partner acceptance. Is that always going to guide our decision? It can be taken into account for sure, but it's always going to be up to our patient. So I had a husband and wife that came in today, and they had already struck me as weird. You know, when we just have that feeling. So he was a very, very large man, and she was a very, very small woman. So they already just looked odd. But people probably say that. Tall, big. He was very big, and I'm talking like 6'5", like probably 250, and she's like 4'5", like abnormally large and abnormally small. So it was already just like caught your eye, right? He never stopped touching her. And like, I don't know, you can have like your hand on your spouse's leg or maybe holding hand. This was like full on petting during the exam. Like I just had a weird vibe. Okay. So I do, and she's 74, mind you. Well, he was not 74. So we all, okay, so we have our pre. Well, and just to make it even better, he's a giant black man, she's a tiny white woman, okay, just to give you full visual effects. So that was I had my first preconceived stereotypical notion. What did you say?
He's just trying to get her money.
That was my first thought. I was like, he's taking care of her because she's gonna croak soon. So I do urine drug screens on all of my patients if I'm giving opiates, and this tiny little 74-year-old tested positive for methamphetamines. So my MA brings it to my attention. Methamphetamine can be from amphetamines, right? Adderall breaks down into methamphetamine. So we look at different isomers. So there's a D isomer and an L isomer. The way I remember, D is drug, bad, okay? Her D isomer was very high. It was a drug. So going into this exam room, what's the first thing that we're gonna do with giant husband petting her throughout the whole interview? So I don't ever ask anybody to leave, but what I do ask is what?
Is it okay?
I ask, am I okay? So first I want to know what's your relationship, okay? Especially because it might raise a bigger red flag if it's like her kid and that's happening, right? So I want to first know, are you the husband? Great. And so I ask, can I speak freely in front of your husband, regardless of what we're going to talk about? And he said yes.
That's not your.
Red flag? I'm already like, well, and so I look right at him and I say, well, I'm talking to my patient. So I turn back to her. Am I okay to speak freely about anything in front of you? And she said, sure. And I said, so you tested positive for methamphetamines. I think it was the only time in my life I actually visually saw somebody's heart drop on this poor man, because you could tell this was like so unexpected that he just like looked at her, stopped petting her, and was very taken aback. But she was very open and honest and told me that she only tried it the one time, because I've ever met anybody that's done meth one time, because a friend came to town and she wanted to do meth. But we, and she's 74. So when I go to prescribe her opiates and she's tested positive for meth, what do I do there? I am not going to prescribe. So most of the time I'll give you like weaning doses if there's something going on, but meth, you can die real easy at 20, let alone 74. So I can't give you anything anymore. But I also have to make sure that whatever's going on there is still going to be a safe situation when she leaves my office, right? So I've already spoken freely. He knows what's going on. Now what do I do?
I didn't know, was the petting continued or?
Petting has ceased. Yes.
Okay.
There was a physical heart dropping, removing of the petting situation. But that was actually when I wanted to remove him from the situation, to make sure, because I can't get a good grasp on how safe you feel if he's sitting next to you, right? So An easy way for me to do that is say, well, I am gonna get another urine drug screen today. I'm not prescribing anything. I don't need another urine drug screen. She's discharged. But it gets her out of the room and into the bathroom so that I can grab her and pull her into another room and speak to her. So there's always a way that we can manipulate situations so that we can find out, are you safe? Is there anything that you need from me? And anytime we have that weird gut feeling, go with it. I would much rather, she did say that she felt fine. And he didn't give me a scary vibe. It was more just a weird vibe. So, but in a private room, I did make sure like, okay, I'm not going to do your medications. I can see that this wasn't something that he knew about. Are you okay leaving here? Because I could always interfere and just not let them go back in a room together, right? I would have the ability to interject if I needed to. So we can always find creative ways, and going to the bathroom is a really easy way to manipulate the situation, because even if she wanted him to go to the bathroom with her, I wouldn't allow that because I'm getting a urine sample, right? And I need to make sure that it's my patient. So that's not a rule for you, that's a rule for everybody. So I have an easy way to get her out of that. So we do want to consider partners' feelings, but at the end of the day, we're always going to listen to our patient and respect what our patient wants, not just what their spouse might be saying in the room. So when we go to pick medications, a good place to start is we want to exclude anything that's going to be completely contraindicated or even relatively contraindicated. So if they have any kind of health concerns, maybe they're at an age where we don't want to do a certain method. So if we're trying to decide if they have any contraindications, we want to use the estrogen. So the use of estrogen is going to help kind of guide us in that. So delivery mode is also going to be a good way for us to decide. So we want to know, how well are you going to comply with this medication regimen? I told you about when I was in Mexico and I asked my daughter if she had her thyroid medication with her. Oh no, did you leave it at home? No, I ran out a month ago. Do I think she's going to be compliant with birth control pills? Probably not going to trust her with that, right? So make sure that they can comply with that dosing regimen, whatever it looks like. And then we want to fine tune it based on changes. So if we're going to change bleeding pattern, is that going to be a positive thing? Are they already very regular and we might disrupt that? So things we would take into consideration. The side effect profile is going to be a big consideration there. Do they have to be discreet with their partner? So do they have that partner that doesn't believe in birth control, that really just wants to get her pregnant? So we can't have her carrying around a pill bottle that he can see is clearly birth control, taking those every day. So sometimes we actually have to conceal that contraceptive, maybe not from a partner, maybe from mom or dad, that maybe their mom and dad think they're too young to have sex. They're having sex anyway, so we're going to put them on birth control. So we might want to conceal it for it that way. So daily pills or wearing patches, probably not going to be the best idea for those patients.
How does it work again with minors, and what age can we prescribe without parental consent? 13.
13? Okay. And I don't do anything pediatric, so if Tori says 13, oh, if Emily said 13, then we're going to listen to that because I don't do anything pediatric. I do know that when my daughter went to her pediatrician to get on birth control, he said, I don't prescribe that, and sent her to an OB. I probably shouldn't talk about her so much since you guys know her now, huh? Sent her to an OBGYN, and since she was not having sex, they didn't want to see her. So where the hell do you go?
My daughter just recently started birth control and she went to her pediatrician, her pediatrician is female. But they do a very, very thorough interview, and she even talked about, like, my daughter remembering to do homework and stuff like that to determine if she should be putting her on a pill or going straight to a shot.
Sounds like a thorough, good doctor.
Yeah, I love her, she's great, but I mean, like, really thorough. And I was there because my daughter talked to me about wanting to do that because of the new laws that were passed and her concern, because she's very well developed. So I was there during the whole thing, and I got to hear how the physician interviewed my daughter about the need for it from a pediatric standpoint.
And part of that, you're going to be stealing for your interview process when you get into
I don't
practice.
take care of kids. I don't take care of kids. But she was very thorough, and was able to talk with Kaylee to help make the best decision for Kaylee, whether that be a pill or a shot.
That's
But she
awesome.
said that she doesn't like to do the patch because kids are sweaty and stuff and it affects the effectiveness of the patch.
Patches are really hard just in Arizona,
Yeah.
period, just because it's so hot. But I told you my experience with birth control as a minor, so hello, Bryson.
So you're saying the OB didn't want that she was underage?
Mhm.
Okay.
She was underage and not having sex, so they don't do a pelvic exam, so they didn't want to prescribe anything.
But if you were 18 and still, probably still.
Then maybe, but yeah, that at that point, her only option is Planned Parenthood. Planned Parenthood's really hard to walk into.
Okay.
If you guys have ever had to, or even watched the news, like people don't walk into Planned Parenthood with a positive experience. They meet you at the car with a security guard and somebody armed walks you into and out of the clinic. So, I mean, that's daunting. And I can only imagine being a 16 or a 15-year-old girl having to go through that. What are the odds that I'm going to be going back there? What are the odds I'm even getting out of my car if I go somewhere that protesters are standing outside yelling at me?
Well, we always come in there for.
Exactly.
Like, I happened to go and like, for my insurance purposes, it was free to get my implant at Planned Parenthood. I'm like 30, years old. I'm a confident woman. And I was like, oh my God, this car. I mean, I didn't. There was active protesters and everything. And I'm like, I would be like, it's not your abortion. I mean, because it is, I didn't like it, but it is what it is. And that's where I go.
Yeah.
They no longer require public exams, just in case anybody's wondering.
So this clinic did.
So yeah,
No longer. I remember when I was a teenager, I had to get a public exam to go on it, but no longer do they require.
Yeah, only if you're sexually active will they want to do a public exam. Yeah. Okay, another big barrier is going to be cost. So if a patient doesn't have health insurance, or if they don't have prescription drug coverage, so there are a lot of nonprofit contraceptives out there, and usually they'll do it based on a sliding scale. So they'll look at your income, and based on your income is how much you can pay. But a lot of these medications, this can cost anywhere from $30 to $100 per cycle of medication. So we always want to try to do generic substitutions whenever we can. Walmart has a $4 list, so trying to find any medication that falls on that list. Injectables are going to be a lot higher, and there's also going to be the office visit that's going to be required for that injection too. So some non-contraceptive benefits. So we can see a decrease in dysmenorrhea, menstrual irregularities, and menstrual blood loss, lessening of acne and hirsutism, fewer ovarian cysts, significantly reduced endometrial and ovarian cancer risk, lower incidence of benign breast conditions, reduced risk of hospitalization for PID, and then suppression of endometriosis if they don't currently desire to get pregnant. So as far as the drug variables, if we do it orally, it's going to undergo a first pass metabolism in the liver. So this is going to induce liver enzymes that decrease contraceptive efficacy. Agents that treat tuberculosis, barbiturates, anticonvulsants, and any herbal preparation like St. John's wort have shown to increase liver metabolism of oral contraceptives. Irregular bleeding and decreased contraceptive effectiveness can also occur. And then broad spectrum antibiotics have also been shown to decrease serum concentrations of oral contraceptives. Is that important for us in primary care? So if we're prescribing an antibiotic and you are on an oral birth control, what am I telling you to do? Use a backup method. So oral contraceptives, they're traditionally going to be packaged in a 28 pill package. The first 21 pills are going to be the active hormone. The last 7 pills are just going to be an inert ingredient, usually iron. This is going to be what we give the patient to have that withdrawal bleeding. So several brands are available with only 21 active pills. Some of them will take no pill for 7 days when withdrawal bleeding occurs. We've got several products that have that offer extended menstrual cycling. So Seasonal contains active pills for 84 days and then 7 off pills. So they only have to have bleeding every 3 months. So education for our patients for starting methods. Your first pill is going to be taken on the first day of the menstrual cycle. We don't need any backup method during this initiation because ovulation is going to be suppressed with that first cycle. So many pill packages are going to have the patients mark the start day to keep track of their pill taking. A lot of them just mark Sunday as the default start day. So Sunday start, the first pill is going to be taken on Sunday following the start of menses. So we do want a backup method for the first 7 days. Starting on Sunday is just going to be a more convenient way of having menses only occur during the week. Is that more fun? I don't know if this is more fun. Or we can do a quick start or same start. So first pill is taken on the day of the office visit. Backup method is going to be used for the first 7 days. So we want to do this only if we're relatively sure that the patient is not pregnant at the time. So patient education, the big thing that we want to educate them to learn about is what to do if pills are missed, and then side effects. So these are going to be specific for which medication they're taking. As far as education, we also want them to know the reason for taking the drugs. Is it for contraception, or if we're giving it for one of those off-label uses? And then we want to talk to them about any adherence issues. Are they showing up to their appointments when they're scheduled? Are they filling their prescriptions every 30 days? All right, so what do I do if I missed pills? So if I've missed 1 active pill, we're going to take it as soon as you remember. Take 2 pills in 1 day if you missed the pill the day prior, and we want to use backup for 7 days. If I missed 2 to 4 active pills, we're going to take 2 pills for 2 to 3 days, also using backup for 7 days. If I missed 5 or more active pills, we should probably come up with a new method, but we're going to start a new pack on the next start day, which would be that Sunday for Sunday starters, and use backup contraception until 7 days of retaking the active pill. We also have a topical patch. So this is going to be applied once a week for 3 weeks. And then 1 week is going to be patch free with withdrawal bleeding to occur. So we're going to initiate this on the first day of menses. If it started on another day, we're going to use a backup method for how many days? 7 days is always our default. So patch location, we're going to educate them to rotate the location placed on skin that is clean and dry. It is weird that we have to educate our patients on where to place patches, but I learned that the first time I had a patient come in with a fentanyl patch in her armpit. And maybe, I don't know. But we want him to place it on the abdomen, upper torso, outer arm, or buttock. Side effect here is going to be similar to your oral contraceptives with the exception of skin irritation, which can happen at application site. We've got the Nuva ring. Who wants to tell me about the Nuva ring?
I do.
Thanks.
Yeah. It is a contraceptive, estrogen, and progesterone combination. Prevention of pregnancy. There is an off-label use for abnormal uterine bleeding, dysmenorrhea, menstrual suppression, polycystic ovarian syndrome in patients with menstrual irregularities. Action, combination hormonal contraception inhibits ovulation via negative feedback mechanism on the hypothalamus, altering the normal pattern of gonadotropin secretion of follicle stimulating hormone and luteinizing hormone by the anterior pituitary. The follicular phase, FSH, and mid-cycle surge of gonadotropin are inhibited. Alterations in the genital tract also occur, such as changes in the cervical mucus, making conditions unfavorable for sperm penetrating even if ovulation does occur. It is duration, serum levels decrease after 3 3 weeks of continuous use. Absorption, rapidly absorbed. Let's see. Bioavailability, vaginal, half-life, elimination is 45 hours. And then it is excreted in the urine, bile, and feces. Common side effects: headache, mood changes, decrease in sex drive, vaginal irritation or discharge, pain in the cervix, nausea, vomiting, stomach pain, acne, weight gain. Serious side effects can be signs of stroke, sudden numbness or weakness, sudden severe headaches, speech problems, problems with vision or balance, signs of blood clots, heart attack symptoms, toxic shock syndrome, which is sudden fever, body aches, skin rash, vomiting, diarrhea, feeling dizzy or lightheaded. Let's see. NuvaRing is contradicted in females who have or develop the following conditions at high risk for arterial or venous thrombosis, liver tumors, undiagnosed abnormal uterine bleeding, pregnancy, and let's see, precautions: bleeding irregularities like amenorrhea, spotting, or unscheduled bleeding can happen. Increased risk for VTE with use, caution use with patients who have other risk factors for VTE, smoking, obesity, family history. Monitor blood pressure in women with well-controlled hypertension. Monitor pre-diabetics or diabetic women. Monitor lipid profiles and monitor for signs of vision changes or signs and symptoms of depression. Patient education. Check and make sure they are checking for presence of the NuvaRing in the vagina regularly before and after intercourse. Amenorrhea can occur. Pregnancy should be ruled out if amenorrhea occurs. NuvaRing does not predict against HIV and STDs. Grapefruit and grapefruit juice may interact with the NuvaRing and lead to unwanted side effects. Avoid use of grapefruit products.
Shocking, huh?
Yeah, right.
So who do you want to recommend the vaginal ring to?
Nobody.
Such an old
Contraceptive method. Really old.
It is an old one.
Uses that one.
And this one would really just be for that patient that can't remember to take a pill every single day. So we want something that's going to be a little bit longer term for him. All right, progestin only. So we've got 2 brand name progestin onlys, Micronor and NorQD. So these have no estrogen in them. So we're going to use these in just special populations. So if we have a patient that estrogen is contraindicated because of any kind of medical condition, or if the patient's breastfeeding. So these pills have very low levels of hormone, which means patients have to be very, very diligent about how they take these. So these work by thickening the cervical mucus and preventing sperm penetration. So this occurs 2 to 4 hours after administration and diminishes after 22 hours of administration. So what happens if I miss a pill? You get a baby. So even taking a pill a few hours late in this category can lead to pregnancy. Common side effects are going to be changes in bleeding patterns and then breast tenderness. We've also got injectable progestins. So this would be Depo-Provera. Who has this drug?
I do.
Tell me about it.
The generic name is hydroxyprogesterone. The goal is to treat secondary amenorrhea, endometrial hyperplasia, abnormal uterine bleeding, osteoporosis, vasomotor symptoms and menopause. Let's see, pregnancy, prevent pregnancy, and manage pain and endometriosis. Mechanism is unknown, but it's thought to suppress FSH and LH to prevent ovulation. It is metabolized by the liver and excreted in the urine. Side effects include nervousness, headaches, depression, acne, changes in appetite, weight gain, excessive growth of facial and body hair, hair loss, and osteoporosis. It is contraindicated in breast cancer and family history of breast cancer, diabetes, excessive fat in blood, porphyria, depression, high blood pressure, disorders of the blood vessels of the brain, obstruction of the blood vessel by a clot, thrombophlebitis, people that are at risk for formation of blood clots, severe liver disease, breast nodules, osteoporosis, decreased calcification or density of bone, visible water retention, weight gain. Should be used cautionary in patients that have blood clots, unexplained vaginal bleeding, asthma, abnormal breast exams, family history of cancer, daily use of alcohol and tobacco, depression, diabetes, eating disorders, cardiovascular disease, hypertension, kidney disease, liver disease, migraine, seizures, stroke, or TIA, and osteoporosis. Monitoring, you want to assess blood pressure before and during therapy, exclude if you could be pregnant, assess acne lesions before and during therapy, monitor their hepatic function, their LDL, HDL, and the serum alkaline phosphatase. For patient education, you want to educate on signs of fluid retention according to the PCP. Advice that smoking will increase risk of clots. They need to make sure they're getting adequate dietary calcium and vitamin D to prevent bone loss. Advise importance of receiving the shot every 3 months for contraceptive use. And basically a lot of the other things we talked about, oral contraceptives.
Tell me what the black box warning is.
And I did not put that down.
So we have a black box warning for Depo-Provera because we see a decrease in bone density with longer term use. So warning states it should not be used for more than 2 consecutive years. If we have any other alternative that is acceptable. So before we give Depo, we're going to make sure that we exclude pregnancy. So let the patient know that if I inject this and you are pregnant, there's no way to reverse this. So we do want a negative pregnancy test before we do the injection. Next, we have Mirena. So an intrauterine progesterone. Who has Mirena? Tell me about Mirena.
The generic is called levonorgestrel releasing intrauterine system. The trade's Mirena. Pharm class is progestins. It's a long-releasing type of intrauterine device or IUD. It's like a T-shaped frame that is injected or goes in the uterus. Mirena is indicated for prevention of pregnancy for up to 7 years. Replace after the end of the 7th year, and also for heavy menstrual bleeding, and it can be used for that for up to 5 years. It releases approximately 20 mics a day, and kind of goes down for years. Side effects are pelvic pain, vaginal itching, infection, irregular menstrual periods, changes in bleeding patterns of flow, stomach pain, nausea, vomiting, bloating, headache, depression, and changes, back pain, breast tenderness and pain, weight gain, acne, changes in hair growth, loss of interest in sex, and puffiness of your face, hands, ankle, or feet. For teaching, advice doesn't prevent STDs or STIs. There's a risk of ectopic pregnancy with Mirena. So advise your patients on that. There is still a risk of intrauterine pregnancy with this. There's a risk of sepsis, pelvic infection, perforation, and expulsion of the uterus, ovarian cyst, and then bleeding pattern alterations. That's my effort.
Okay. There's only one other one that came out called Skyla, which is just a nice fun name for your intrauterine. isn't it? So Skyla is also approved by the FDA that you can leave implanted for 3 years. It's smaller in length and width than the Mirena. It has a smaller insertion tube, and it also has a silver ring at the top of it, which makes it so that we can actually visualize it under ultrasound. Smaller size makes it easier for patients that haven't already had a pregnancy. It's just as effective, just smaller and a little bit easier to see. Next, we have Implanon. So this is contraception for up to 3 years. It's the only implant that's currently available. So this one is going to have one rod that contains 68 milligrams of atenogestrel, which is an active metabolite of destrostrel. So overall serum progesterone concentration is going to be lower than that Norplant. Norplant's no longer available in the United States. Since this one is only one rod, insertion and removal are simpler than the, what's it called? Norplant, sorry. All right, and last we have the emergency contraception. So this is for pregnancy prevention after an episode of improperly protected intercourse. So we want to have our patients take this as soon as possible within 72 hours, but it can be initiated within 5 days. Improperly protected intercourse occurs if no pregnancy prevention was used, if the method fails, like the condom broke, or if they missed too many pills by taking their oral contraceptive wrong. So this one's Plan B, one step, or there's also next choice. These are going to be progestin only products that are packaged specifically for emergency contraception. So these are available now over the counter. You do have to be 17. Traditional dosings, 1 tablet, 12 hours apart, but taking both doses at the same time does not decrease efficacy, and it's just easier to have our patients do it that way. So monitoring, we want routine female screening, doing a really thorough history, doing breast and pelvic exams, pap smears to rule out any STIs, and then making sure we're checking blood pressure. And then we're just going to be monitoring specific to whatever contraceptive we're going to prescribe. So physical exam, we're doing breast exam, pelvic exam, pap smear are not going to be required for contraceptive prescription, regardless of what your own beliefs are. And then make sure we're monitoring blood pressure and adverse drug reactions at least every 3 months until we're stable, and then just annually after that. You guys need a break?
Yes.
So what does the NP take into account concerning pharmacokinetics? Pharmacokinetics, the movement of the drug. I need to be concerned about bioavailability, correct? What statement by the patient tells the nurse that they understand the education regarding heparin? So for me to know teaching about heparin, I need to know concerns for thrombocytopenia can occur by when? Day 4. So my answer here is what? I have to have my platelets monitored every 2 to 3 days for thrombocytopenia that can occur on day 4 of therapy. What educational statement by your patient tells you that the patient understands the use of warfarin? I hate these answers, don't you?
Yes.
Is there any way to avoid all foods that contain vitamin K? So my education can't say all foods. I need to avoid foods high in vitamin K. Exactly. It would be impossible to do the other. So the correct answers here is going to be C, avoid foods high in vitamin K. What education should you include when you're educating patients on ESAs, erythropoiesis stimulating agents? We know that there is a risk of what? Tumor development to cancer patients if we give them ESA therapy. So specific to cancer patients. You believe the patient understands the education regarding iron supplements when they state what? What does orange juice do with iron? Helps us absorb it. So taking Iron with orange juice is a good thing. It'll actually help with absorption. You know that gliptins help diabetics because they do what? We just learned that, what did we? We just learned that gliptins are going to act by directly binding to the receptor on the pancreatic beta cell. So that top one is our correct answer there. You understand that diabetics can benefit from GLP-1 agonists because they do what? Oh, I screwed that up. I did that backwards, I'm sorry. Go back to your gliptins. Because I answered about GLP-1s, not gliptins.
So this one's B.
Ah, sorry.
Wait, so what? 6 is B.
So yeah, gliptins act on the incretin system. I'm sorry.
Oh, thank God.
So I lied to you. Gliptins are going to indirectly increase insulin production. Gliptins are, which means that GLP-1s do what? They bind directly to the pancreatic beta cell. I apologize. You have a patient with chronic renal failure. They become anemic. So you prepare the patient for what? We want to give them Epigen, those epoetin alpha medications. You believe the patient had adequate education regarding iron supplements when they verbalize what? Iron, I want to draw what at 4 weeks? I want an H&H and a ferritin 1 month after starting therapy. So CBC in 4 weeks is the right answer. ACE inhibitors help patients with heart failure by doing all of the following except what? Yikes. Do we want an ACE inhibitor to increase heart rate and preload? No, so it's going to be all of those except increase heart rate and preload. C is the right answer to be the wrong answer, right? Your chronic pain patient calls for a refill on the regularly prescribed hydrocodone. The appropriate action would be for you to do what? I agree with 77% of you. I want them to come in for an office visit so I can talk to them about it, right? What portion of the patient's history should be thoroughly assessed before prescribing Flagyl for BV infection? What can you absolutely not do with Flagyl? Drink alcohol. Remember, it will make you feel like you have the worst hangover of your life. So we want to do really good social history to see, are they social drinkers? And what does that social entail? Because you have to completely avoid alcohol with Flagyl. And yes, I say Flagyl because I can't say that word. When prescribing lithium, you educate the patient that all of the following will need to be closely monitored throughout therapy, except what? Oddly, it's liver function. So lithium's going to have no implications as far as our patient's liver function. So we're not doing routine monitoring. It will affect renal, sodium, and thyroid functions, however. You have a 32-week pregnant patient that comes in complaining of contractions. You educate the patient regarding the following. What are you going to do for her?
This is a weird question. I feel like my answer is not pharmacological.
I would want my answer to be pharmacologically related. What medication is going to relax, smooth the muscle contraction? Beta 2 agonist, and that's what I want you to get the takeaway with that one. What med do you order after the patient experiences hallucinations following atropine for their bradycardia?
Really, none of us knows it right.
To reverse that atropine, I could give physostigmine.
Of course you could.
Silly us.
I clicked the wrong one. What condition would be appropriate for you to prescribe clonidine extended release to an adolescent? Confidence there. Yeah, clonidine extended release we would give for ADHD patients. That is 100% correct. You educate the patient to watch for which adverse effects when you discontinue baclofen. Whoop, whoop. Lethargy is like lethargy, but different. It's worse. Do we give baclofen for muscle spasms? We give it for spasticity. So when we abruptly stop baclofen, we can cause our patient to have hallucinations. I love that you guys all fix your answers after I say it. Lab work shows a decrease in creatinine clearance after the patient starts taking memetine. The appropriate course of action would be to do what with your medication? We just want to decrease the dose with most medications. Usually we just have to alter the dose. We'll do a renal dosing of this medication. You believe the patient's caregiver needs more education because she verbalizes which of the following regarding rivastigmine transdermal patches? You hate pharmacology. Rivastigmine patches should be changed how often? Every week.
Yeah, I was like 100 for the first 4 questions.
You gave your patient a first generation antipsychotic. What adverse reaction, which will you expect the patient to have that you also now have to treat? We know first generation antipsychotics are going to cause what? Tardive dyskinesia. Easy question.
No. Yeah. Next week.
It's not next week, but last time I taught this class, we were a week ahead. Or no, I probably just did this next week or the week after.
Yeah.
So who's saying no?
Well, it's not next
It's
week.
not next week.
Okay, okay. As long as it's a semantics answer. Okay, okay. That's all I had for this week. We'll do another one next week. So
Are we doing,
don't,
like a group
Oh, I got-
collaboration, or are we doing like individual?
That's funny, guys.
It's also about.
No, she's talking about.
I'm gonna come and say exhausted mom. I don't have time to dress.
anybody doing couples? Is that what you're asking? Couples?
Yeah.